All right. Good morning, everyone. Let's go ahead and get started. It's great to see you all. I'm Anna Marotra from the Water Environment Federation. Yeah, you've probably gotten a lot of emails from me, so thank you for your patience. But I want to welcome you to the 4th annual Wastewater Disease Surveillance Summit. So I'm going to just say a few opening remarks. We're going to get through some housekeeping items, and then we're going to get underway with what is a fantastic 2 days of programming. All right. Okay, so I think about this a lot, and it really sounds trite, but if you think about where we've come in the past 5 years, we've come a long way, right? The National Wastewater Surveillance System and all its related programs and efforts were born, out of an emergency response to an unprecedented global crisis, but have evolved into highly trusted sources of public health insight. That's a huge accomplishment in 5 years. And each and every one of us in this room have played a role in building this national network. And if you just think back to a few years ago, we were doing this construction, under pressure during a pandemic with a lot of uncertainty, with not enough money, with not enough people, with not enough respect. And if you think about a lack of money, a lack of certainty, and a lack of respect, that's where we are again today. But our experience in those early days should remind us of something very important. If we're able to build all this in such challenging times, I have no doubt that we can weather the headwinds, political and financial funding related, that we're facing right now. As a community, we are innovative, we are resilient, and we are collaborative. So we've got this. I have faith in us. So we might be entering kind of a new phase, a new chapter in all of this, but the mission remains the same, and that is to be continuously finding better ways to get information out of wastewater to inform public health decision-making. So let's use this chance together over the next couple of days to reflect, to regroup, to recharge, and to create, think imaginatively about where we want this field to go in the future. So thank you all for being here. Thank you all for what you have done to get us to this moment. And like I said, this moment is a really good one because we have 2 days of fantastic programming for you. So let me get some housekeeping things out of the way. All right. So you've seen a few QR codes floating around, perhaps on a piece of paper, printed out on a piece of paper. That is your passport to the next couple of days. So this is our digital agenda. You can access it using the QR code or just using bit.ly/WDSS. Oh, that is not correct. WDSS 2025 is what you want to use. I am missing a slide in here, and this is just what happens, and we're just going to go with it. But there are QR codes floating around, bit.ly/WDSS 2025, and WDSS are all capitalized. So that's what you want to use, and we can pass the QR code around. Okay. If you came in that way, you probably saw the registration table. Please do make sure that you sign in both today and tomorrow. That's one ask of you. Was everybody able to get that? Maybe Carly, do you want to pass around like that QR code that's on the table or something? Is everybody able to get on the digital agenda? Yay, I'm seeing nods. Help your neighbor if they're having trouble, okay? So that digital agenda is your one-stop shop for all the information. Thank you, Carly's doing a very nice job of highlighting the QR code. That's your one-stop shop for everything related to the next couple of days. So you've got your schedule on there. You've got the names of your presenters. You've got your speaker bios. You've got lunch options. You've got a link to a feedback survey that we're going to ask you to fill out tomorrow. You've got information about the meetup later today. There's safety information, social media guidelines, anything and everything you probably want is in that digital agenda. But if you do not find an answer to your question, or you just want to chat with us, come talk to us. We are your facilitators. So it's Stephanie Birch-Murbach and Angela Raby from the California Department of Public Health. Can you wave your hands? I see one. Awesome. Here and here. And then either me or Carly Trans from WEF. Carly's in the back. Okay, so yeah, we are here to help you. Another person who you might notice standing in the back is Heidi Bragg. So Heidi is one of our WEF colleagues. She is the Senior Director for Public Outreach and Communications. I got it right this time, Heidi. So say hi to her. She's going to be taking photos and videos. She might come up and ask you questions. Feel free to interact with her or not. Feel free to post things on social media or not. If you do, you can use this hashtag WDSS25. So that's Heidi. Okay, now we're getting to a different QR code. Today from 4:30 to 6:30, there will be an informal meetup at the Karl Strauss Brewing Company. So, and there's information in the digital agenda about how to get there. We'll share that information again at the end of the day. It's very easy to get there. We'd love to have you join us. Our only favor that we're asking of you is to use this QR code or that bit.ly link right there and let us know if you're going to come, because we do need to call the venue later today and tell them about how many people are going to show up, and we hope it is all of you. Oh, also free Wi-Fi. You probably noticed that. TCE guest is what you want to use, and there's no password. Right. Did I miss anything, fellow facilitators? All right, I think we're underway. So here we are, the first part of our programming. We're going to hear first, and it is my great pleasure to introduce our keynote. This is Dr. Erica Pan, who is the Director and State Public Health Officer for the California Department of Public Health. She has an incredibly impressive resume and bio. I am not going to read it all because it is all in your digital agenda, but just let me emphasize how lucky we are to have her joining us today. And so I'm going to go ahead and just bear with us for about a minute, because this is our first time switching over to a virtual presenter. She's joining us virtually. We're going to figure it out. Just give us a minute. That was easy. Dr. Pan, we can see you. It's all yours. Take it away. And you are still muted. Okay, perfect. Thank you.
Great. Can you hear me okay?
Perfect.
Okay, great. All right. Well, good morning, everyone. Welcome to the 2025 National Wastewater Disease Surveillance Summit, which CDPH and the California National Wastewater Surveillance System Center of Excellence are proudly hosting together, along with the Water Environment Federation, or fondly known as WEF. Thank you so much for inviting me to speak today and help set the stage for your time together over the next couple of days. As we continue to try to build a stronger public health future during uncertain times, wastewater continues to be an important pillar of public health surveillance that's nimble and efficient and doesn't rely on health-seeking behaviors. The same wastewater infrastructure that was built for COVID-19 continues to be leveraged in new and innovative ways to support local and state and national public health. And it's increasingly used by providers and even the general public to follow trends for many diseases. Actually, I'm remembering early discussions in 2020 and meetings with our prior California Secretary of Health and Human Services, Dr. Mark Galley, our Environmental Health Director then, Mark Starr, and Dr. Zukuja and James Watt from our Center for Infectious Diseases about the idea of embarking on wastewater surveillance and what it would take to stand it up. We managed to get some seed state money then and some ELC money, and worked with partners across our department, including environmental health, infectious diseases, our water and viral labs, and many, many external partners, many of you in this room today. Not only did we get more investment with that, but we named wastewater surveillance as a public health tool that we gained from the pandemic and that we wanted to maintain and broaden in our governor's smarter plan as we demobilize from the pandemic. Now, it's so great today to see how far we've come with surveillance for multiple diseases and new uses, most recently across a One Health approach during H5N1 that we didn't even imagine then. All of this progress has largely been due to the different groups in this room and this virtual room, people in public health at all levels, academics, utilities, private sector, all working and learning together. Some of the high-level accomplishments that we want to highlight today and tomorrow include continuing expansion of wastewater nationally within the CDC's National Wastewater Surveillance System, including hundreds of sites from around the country. And we now have wastewater surveillance coverage in almost every state in the country. Here in California, we call our CDPH program the California Surveillance of Wastewaters, or Cal Sewers. And we support wastewater testing for 36 wastewater treatment facilities in the state. Beyond those sites, we also have partnerships and data infrastructure building, and we're proud to have wastewater surveillance network that includes data from multiple other programs doing this wastewater work in California, such as Wastewater Scan and the CDC's WDSS program. Together, our California Wastewater Network represents over 90 sites in California, bringing all of that data together and summarizing and interpreting it for public health use. These data represent 6 regional health officers regions in our state and more than 60% of our California population, which is over 24 million people. Some of our key partners, again, are Wastewater Scan and the CDC wastewater surveillance testing program, all of the participating utilities who still send samples voluntarily, as well as our local health departments. We also wanted to highlight the innovative uses of wastewater surveillance methods that are continuing to be developed around the country to monitor for different infectious diseases like pertussis, parvovirus, and for other organisms with important antimicrobial resistance genes. We've also seen different public health uses around the world and the country, such as monitoring at mass events like the Paris Olympics and even the recent NFL draft in Wisconsin. Many of these efforts are only possible through the continued work and collaboration by many in this room. And these are partnerships, again, across national, state, and local public health departments, academia, utilities, and the private industry. You're going to hear more during your conference about innovations in assay development for new pathogen targets, advancements in sequencing of wastewater surveillance using mobility data, which again, I remember using during the pandemic, and really look forward to hearing how you all might match that with wastewater surveillance, and other new lab methods and new applications of wastewater surveillance data and modeling. In California, we continue to add wastewater monitoring uses beyond COVID. Some examples here include using it for situational awareness and public health actions, such as routine monitoring for a lot of different diseases, including flu, RSV, Mpox, and also norovirus, dengue, Candida auris, hepatitis A, norovirus D68, and most recently measles through our partners at Wastewater Scan. We've also seen continued use cases of wastewater surveillance at local health departments to inform decision-making, public health messaging, and to guide resource allocation and outbreak investigations, including, for example, recent uses of wastewater data to increase local awareness of Mpox and measles to healthcare providers in at-risk communities. We've actually seen it have some early detections when no cases had been reported, and being able to, again, increase awareness for increased clinical testing. In addition, wastewater has also continued to play an important role in public health emergencies and emerging pathogen response throughout the country, something the California Center of Excellence is proud to be leaders of. We know that part of today's discussion will include applications of wastewater surveillance from a national, state, and local perspective in response to pandemic preparedness. And, for example, in California in the past year alone, together with our partners at Stanford and Emory who run the Wastewater Scan program, and our Center of Excellence utility partners, we've leveraged wastewater surveillance to be rapidly adapted and deployed to support our public health response for Clade 1 Mpox, H5, and again, now measles. For Mpox, we were able to use wastewater surveillance in 2022 during that initial declared emergency and help our state with our Clade 2 Mpox response. And then last year, we again used it to support our state and local health departments for Clade 1 Mpox detections. We've also been able to incorporate wastewater surveillance into our state H5 response. And this gave us really important and useful One Health tool that provided insight into our H5 dairy herd infections. We learned a lot about dairy processing plants and where those were located and where we saw signals increasing there. And we learned that this can be a useful early indicator for future outbreaks or if human-to-human transmission were ever to become sustained. We've definitely seen correlations with our wastewater surveillance trends with what we've been seeing in our herds as well. We've also been monitoring measles in California with our SCAN partners at several sites for over a year, and this has since been scaled up across the state and the country. Through that program, we've even just in the past few weeks had detection of wastewater in areas without known cases. And again, suggesting the potential presence of undetected measles and increasing awareness for clinical providers and local health departments to increase messaging. So wastewater surveillance continues to be a new and model collaborative for public health. It's a bridge between a lot of different worlds, something that we couldn't do both without technological advancement in the lab and methodological advancement by epidemiologists to interpret and use that data. But it's more than just a collaboration between lab and EPIs. It also requires working with experts from many other fields, including environmental engineers, environmental scientists, genomicists, and as our H5 experience emphasized, with vets and animal health experts as well, including wildlife, departments of food and ag, and others. You're going to hear from various speakers today on how to implement wastewater surveillance in low resource settings as well, and innovative ways to expand access to this important public health tool. You'll also hear similar themes throughout the conference of collaboration across fields, innovation, and problem solving. You'll tackle topics ranging from research priorities and uses for public health, communication strategies, ethics, what levels of surveillance, generating quality lab data, and health and safety concerns. And as we move together towards a safer and more equitable future, these collaborations and innovation will continue to be important to drive all of this forward. As a National Wastewater Surveillance Center of Excellence in California, we have the opportunity to support and learn from all of your jurisdictions as well about how we can continue to develop wastewater surveillance. And we'll continue to learn from others in the field, including CDC, WEF, APHL, other centers for excellence, other state and local health departments, and again, the great academic partners and utilities and private partners across the board as well. This is truly a critical time in public health, and the ongoing collaboration of developing this new tool is not only remarkable, we should celebrate above and beyond the broad value noted in the ongoing support for this new cross-sector capacity gain. Thank you so much again to WEF for co-hosting and co-sponsoring, and the California Endowment for being able to provide such a great venue to come together. And I hope you all have a wonderful 2 days of collaboration together. Thank you very much.
Thank you so much, Dr. Pan. All right, now it is my pleasure to introduce my colleague. Again, we're just going with it. You guys can all see that that says City of Tempe, Arizona. It is my pleasure to introduce my colleague, Carly Trans. We have a little treat for you. This isn't actually on the agenda per se, but I don't know if some of you may recall that we had a call for success stories and we got some wonderful submissions to that. We had collected some other success stories over time. So Carly's gonna come up before each session today and highlight 3 of the success stories. So I will let Carly take it away.
Thanks, Anna. So the City of Tempe, Arizona operates a comprehensive wastewater biointel program that monitors 11 sewer sheds covering 100% of the city's sewered population. Using 24-hour composite samples collected from manholes 2 to 7 times per week, the program provides high-resolution neighborhood level data on a wide range of public health indicators. Samples are analyzed for a diverse panel of targets, including respiratory viruses such as SARS-CoV-2, influenza A and B, and influenza A H1N1, and RSV, gastrointestinal viruses like hepatitis A and norovirus, vector-borne viruses such as West Nile virus, and other viruses including adenovirus 41, pan-adenovirus, and enterovirus D68. In addition to infectious disease surveillance, the program also monitors opioid use by testing for substances such as fentanyl, norfentanyl, heroin, oxycodone, and codeine. Laboratory analysis is conducted by a network of partners, including the Arizona State University Biodesign Institute, the Arizona State Public Health Laboratory, the Translational Genomics Research Institute North, and Murray State University. Tempe's approach to wastewater surveillance is designed not only to monitor public health, but also to inform strategic policy and operational decisions. The city uses wastewater data to guide education and outreach efforts related to emerging infectious diseases and behavioral health risks. These insights support collaboration with health agencies and service providers to improve prevention programs and treatment services. By integrating wastewater data into local decision-making, Tempe has positioned itself as a national model for community-level public health innovation. To promote transparency and community engagement, Tempe makes its wastewater data publicly available through a series of interactive dashboards. These dashboards allow residents, researchers, and policymakers to explore trends and better understand the health dynamics of their neighborhoods. This open data approach reinforces the city's commitment to using wastewater intelligence as a tool for proactive, data-driven public health action. In Las Vegas, wastewater surveillance is conducted through the Nevada Empower program, a collaborative effort involving the University of Nevada, Las Vegas, the Southern Nevada Water Authority, the Southern Nevada Health District, and the Desert Research Institute. This program monitors multiple locations across the city, including local water resource recovery facilities and high-priority sites such as UNLV dormitories, the Harry Reid International Airport, and the Las Vegas Strip. Composite samples are collected once or twice per week from manholes and treatment facilities to capture a representative snapshot of community health. At the O Laboratory at UNLV, samples are analyzed using quantitative PCR and whole genome sequencing. The program tracks a range of public health markers, including SARS-CoV-2, Mpox, antimicrobial resistance genes, and other emerging threats. The data is used by local and state public health officials to guide timely and targeted interventions, helping to allocate resources more efficiently and respond proactively to potential outbreaks. One notable example of this impact was the detection of Mpox in the wastewater system, which prompted the Southern Nevada Health District to launch targeted vaccination campaigns and public information efforts. Another example involved the repeated detection of Candida auris, an antifungal resistant yeast, in specific areas of Southern Nevada. This finding led to expanded point prevalence surveys in healthcare facilities to assess and contain potential transmission. The Nevada Empower program also emphasizes transparency and public engagement. SARS-CoV-2 data, including viral concentrations and variant information, is shared through an online dashboard maintained by the Southern Nevada Health District. This public-facing tool allows residents, researchers, and policymakers to track trends and better understand the health landscape of their communities. By integrating wastewater surveillance into public health decision-making, Las Vegas has built a responsive and data-driven model that supports early detection, rapid response, and long-term resilience. In Santa Clara County, California, the Public Health Department operates their wastewater-based epidemiology program that provides near real-time insights into community health. The program collects 24-hour composite samples 7 days a week from all 4 water resource recovery facilities in the county. These facilities serve approximately 98% of the county's population, offering comprehensive geographic and demographic coverage. In partnership with Stanford University, the Public Health Department analyzes these samples for key respiratory viruses, including SARS-CoV-2, influenza A and B, and RSV. The data are normalized using pepper-mild model virus to ensure consistency across sites and over time. Through Stanford's Wastewater Scan initiative, additional pathogens are monitored, including human metapneumovirus, enterovirus D68, parainfluenza, norovirus, rotavirus, human adenovirus group F, Mpox, and the antifungal resistant yeast, Candida auris. Wastewater data became a critical component of the county's COVID-19 surveillance strategy. These data were regularly shared in press releases, public briefings, Board of Supervisors meetings, and healthcare provider updates. They informed public health recommendations, including masking guidance and other non-pharmaceutical interventions. Local hospitals also relied on the data for preparedness and surge planning, using wastewater trends as an early warning system for potential increases in clinical cases. The detection of Mpox in wastewater has provided timely and actionable information that complements clinical testing, offering a more complete picture of disease transmission in the community. This has enabled the Public Health Department to respond more effectively to emerging threats. To ensure transparency and public engagement, The department maintains dedicated dashboards for SARS-CoV-2, influenza, and RSV wastewater data. Additional analytes tracked through the wastewater scan program are displayed on a separate public dashboard. So now I would like to introduce Stephanie Birch-Murbach, who is the program manager for the California Surveillance of Wastewaters, CalSewers program at the California Department of Public Health.
Hi, everyone. And thank you, Carly. Thank you, Anna, for all the work that you've been doing to help support this conference. We are so excited that you're here. We're officially kicking off with our Advancing the Field session. So just a little bit of housekeeping to explain how we're going to do this. I'm going to introduce each speaker one at a time. They're going to come up, give their presentation from the podium here. They can go sit back down, but hopefully they don't go too far, because at the end, we're going to bring everybody back on stage for Q&A together. So with our first speaker, very briefly, we're keeping our bios very short because everything is in our program, but I'd like to first invite Dr. Alexandria Boehm to come on up. Dr. Boehm is the Richard and Rhoda Goldman Professor in Environmental Studies in the Department of Civil and Environmental Engineering and the Department of Oceans at Stanford University. Come on up.
Yeah, so it's not May 27th. So I think that was the day it was last week when I turned in my slideshow. So today I'm going to talk about the efforts at Wastewater Scan to expand the targets that we measure in wastewater. I think most people here know that Wastewater Scan is an academic program that works with 40 states across the United States. And so I don't think I need to say too much about this, other than you also know that we partner with a lot of different state public health. We get emails and we do phone calls with people in Maryland, Arkansas, Connecticut, Florida, Texas, all the time. And we also work closely with California. So Marlene Wolf, who's in the audience here, is also an academic partner with the California COE, which I'll talk about a little bit later. But I have an important announcement to make, which is that just yesterday, Wastewater Scan confirmed we will receive funding to continue Wastewater Scan through December 2026. Yes, and we will continue to also run all of the targets that we are currently running, including this third pathogen plate which we just added. So here are all the targets we measure now, and you'll notice some new targets on here. You'll notice that we added back in rotavirus, we added back in adenovirus group F, we added measles and also parvovirus, and we have space for more targets in our digital PCR plates. And you all also know that we do work with Verily Life Sciences, and Amy Lockwood is here today in the front, and they do the lab work for us for Wastewater Scan. And so we're very excited about the fact that we received funding to continue and also add this third plate. And we're also planning to start work on viral metagenomics and seeing if that will work and if we can scale that in partnership with everybody who works with us. So I'm here to not talk about the future of Wastewater Scan. That was something exciting I could add to the talk today, but I was asked to talk about how to add new targets to programs and how we have done it. And so this is a timeline, which I know you can't really see very well, but it shows over time how we've added different targets in the evolution of our program. And so I won't go through this in detail, but you can see little things here, like when we added Mpox clade 1B and when we added our current plate, which has measles and parvovirus. And I can barely even see it on my own screen. And so, as I mentioned, Wastewater Scan, we were born here in California, and we really got our footing and piloted and showed what we could do in partnership with CDPH. I still remember all those early meetings and working closely with Alex when he started, and Duke, who has retired, and sort of socializing these data and beginning to meet many of you in this room and working with you to build confidence in this partnership. We currently work with 28 sites in California, and Stanford and Emory. Marlene, who's somewhere in here, probably knitting in the back, or she's not here, are the academic partners of the COE. She's somewhere in the back. Marlene, do you want to raise your hand? Yeah, okay, there she is. And through our work with the California COE, one of the really important things we do is we pilot our testing of new targets in California. So all the work that we've done to add these additional targets each step of the way has really started in California through our partnership. And I'll talk more about this later, but there's both the laboratory work, but then there's also the socialization and testing of whether these data are actually useful and actionable for public health. And that's something that we've worked really closely with both the state and local public health departments on. And this collaboration really allows for a flexible approach in evaluating new ideas. So I know I'm probably taking too long. The outline of the talk today is I'm going to talk about some of the key considerations that we have when we add new targets, the systematic process we have of adding new targets, and examples of targets that we've added or decided not to add, and communicating and sharing results. So 3 of the things that we think of when we think about adding targets is there a compelling use case for tracking the target in wastewater? Have people in public health told us, wow, it would be great to be able to track this? The other question is the target shed into wastewater at reliable concentrations? Sometimes we just don't know that for sure. And then the third is, can the assay be adapted and designed to test the target in wastewater? And actually 2 and 3 are pretty easy to say yes, yes. And 1 is kind of the hardest one, which is where we rely a lot on our partnerships with public health. In determining priority targets, what we have learned through our work with the California COE in particular, as well as many other public health agencies across the country, is that diseases with significant surveillance gaps are great targets for wastewater. Also diseases that are vaccine preventable, where there could actually be like campaigns to do vaccinations. Diseases that are rare or high consequence, such as Cioris, Mpox, or so-called disease X, and diseases where the underlying epidemiology is less well known, for example, norovirus. So this little diagram here shows all the different use cases that we have so far sort of recognize are important for wastewater. So anytime someone comes around and suggests, a certain target, usually it's because of one of these use cases. It's going to be useful for therapeutics. Okay, moving on. So then we look for evidence for shedding, and actually there's very little literature on shedding from human excretions. It's, most of the results are from clinical testing, positive or negatives. When people go to the doctor, there's no concentration data. And we've done 2 systematic reviews on respiratory viruses as well as enteric viruses, and just found very limited data. This is a research gap. So you can usually find some sprinklings of information through papers about someone confirming, like West Nile virus in urine, for example, that might give some hope to using it for wastewater surveillance. And then the last item here is, can the assay be adapted or designed? Can we design a new assay? So we go through this process of looking for assays in the literature and testing it and seeing if it can work, or designing a new assay altogether. So the process that we use for evaluating new targets, I'm going to skip this slide in the interest of time, is shown here. And many of you have seen this slide before, because we have not changed this process for actually, I remember making this graph in my mom's house in Hawaii, like in 2021 or something, and it still applies today. We select a new target. We then look online for different assays that are available. We do in silico testing to see if the assays will still work with the evolution of the viruses. If it's a virus, we procure supplies, we test the assay in the lab, for sensitivity and specificity in vitro. And then we look for a location from wastewater scan or within California where we can retrospectively apply the assay and test whether it actually works in a place where we might suspect it to be present if there has been like an outbreak from that particular virus. And then we compare the results with the clinical data, and then we will pilot the application of the testing prospectively in a subset of plants that we work with. And usually those are the so-called scan plants, which are the Bay Area plants that work with us that provide a sample every single day. And that's from like Santa Clara County and San Francisco County and Sacramento, for example. So that's typically our process. And that's sort of like the technical side. But alongside that is also working really closely with our public health partners to find out what they think of the results and how they're perceiving them and whether they think they're useful. And I think that's a really important aspect that is not reflected in this particular decision matrix. So here's some examples. When we add new tools into practice, we think about early and often communication with people who are involved in the process. We prepare, once we decide to scale an assay, we prepare talking points and fact sheets and release research results rapidly. So all the questions about sensitivity and specificity, the methods we use are all documented so that people can actually find that information. And then we also provide support and collaboration with public health to interpret their data. So for example, Marlene was on a call just yesterday with Maryland, helping them interpret some new results that came in through wastewater scan that they didn't understand how to interpret. And so we do provide that bespoke sort of support when we need to, and if we can. So this is just an example of our Mpox Clade 1b fact that we prepared for our partners. So thinking about an implementation checklist, we have 3 things we look for: sensitive specific assay, association with clinical cases, or at least results that are not orthogonal to what we would expect, and then public health interest and data utility. So we all know that sometimes there isn't data on clinical cases, so you can't necessarily expect agreement. So for example, we have RSV, which we published in 2022 from some work in 2021. This is a plot from the paper showing RSV at San Jose wastewater treatment plant concentrations, and then the RSV positivity rate in California. In this case, we had a sensitive and specific assay. It was associated with clinical cases, and public health was interested, and the data could be used. So we scaled the assay, and it's been in our program since 2022. Here, what is going on? It's like I have multiple copies of that slide. And then here's an example of enterovirus. So we had an assay for the genus enterovirus. The assay was sensitive and specific. These are data from 2 wastewater treatment plants over time, San Jose and Oceanside. But because enterovirus is such a diverse genus of viruses causing everything from respiratory illness to gastrointestinal illness to rashes, there really wasn't a clear use case for this data. It was just too general. So we decided not to scale it. There wasn't an interest in it, even though in my previous life as someone who works in environmental health and pathogens in the environment, everybody loves testing for enterovirus. And then I know I'm short on time here, and don't know what is going on with this. I have let's see. I don't know, it's not advancing. Here. All right, here we go. So then we have measles. And so we just scaled this assay 2 weeks ago across the country with wastewater scan. And for this assay, we developed a new assay that does not detect the vaccine strain of measles. And so we tested the assay. We know it's sensitive and specific to infectious measles. We don't know if it's associated with clinical cases yet because we just don't have enough data. These are some data from one of our partners that we retrospectively did work with, which I'm not going to name who it is, just showing the presence of the measles target in their wastewater over time. But there's a ton of public health interest and data utility for the measles. So this is a case where we don't have a really clear connection to case data, but we still decided to scale it because of the interest of all of our partners. I don't know why this is not advancing. Okay, here we go. So I'm finishing up now. So the key takeaways is that public health and academic partnerships have provided for us the opportunity to quickly respond to new concerns through our wastewater scan network and through our partnership with the COE. The laboratory procedures that we use are it's easy to multiplex, so it's fit for adding new targets really easily with the digital PCR format. And the structured process that we have for choosing and developing new targets that we've really stuck with, I think adds credibility and trust to what we're doing. And so we think that's really important that that exists, and that level of communication is super important. The measles data that we are measuring just went live on our website yesterday. So if you're interested, you can look at data.wastewaterscan.org and look at measles results as they come in. And we plan to continue measuring measles as long as there's a public health interest. And okay, thank you, everyone.
All right, thank you so much. Thanks so much, Allie. I'm actually going to invite some folks to come sit down, find some chairs. We are very friendly here. We do have some open chairs up front, over here too, and in the middle, just so we can all get comfortable together. So up next, I am going to advance the slide, hopefully. Oh, there we go. I am going to invite our next speaker, Dr. Christian Anderson, to come on up. Christian is a professor at Scripps Research and Director of Infectious Disease Genomics, and we'll be sharing a little bit about advancements in sequencing. Hand it over to you.
Great, thank you, and it's great to be here, and thanks to the organizers. So my group is focused on infectious disease surveillance, broadly speaking. We're trying to understand the emergence, the evolution, spread of these viruses, and then via data integration, try and understand the diseases that they cause as well. And one of the things that we have done in recent years in particular is wastewater surveillance, led by a lot of that is Josh is here and Miriam is here as well. So I'm going to show a little bit of that work. But one specific thing that I want to focus on is the genomics of all of this. The PCR, for example, or other assays that allow for the detection of infectious diseases, for example, in wastewater, which might allow you to understand the burden of a disease. Genomics will add an additional layer on that will allow you to, for example, subtype what type of the variants, lineages you might have of a certain virus. But it might also allow you to do other things, for example, connecting outbreaks and also understanding the emergence of these viruses. So I just wanted to show you one example. This is from clinical sequencing. So this is sequencing from patients with these viruses. But when we are sequencing these viruses, because we have a location and a time associated with these sequences, we can sort of connect them over time and understand exactly how these viruses spread across geographical areas. And here's just an example from 4 of the different viruses that we have worked on. Of course, things like SARS-CoV-2, H5N1, H1N1, and others is exactly the same thing that you can be doing. Now, one of the key aspects of wastewater surveillance, though, has to do with lowering surveillance gaps. And I think surveillance gaps is something that we often forget about. Here's one example from Zika in the Americas. You might all remember this epidemic. And what we can do with genomics is we say that once we have detected something, we can go back in time and saying, when did it actually get into the area and when did it start the epidemic? And when we look at something like Zika, we realized that while it was detected, but by the time that it actually came in preceded that by 1.5 years. So the virus had already been there for 1.5 years in the Americas. It's just we hadn't realized it because we hadn't seen the clinical cases yet. And this is true across a lot of different viruses. And you can think of these viruses as being novel, like SARS-CoV-2, for example. The detection gap there was actually pretty short. It was only about a month. But things like Ebola in West Africa took about 3 months before the outbreak started, and we realizing we had an outbreak of Ebola for the simple reason that nobody expected, although we should have, but nobody was expecting to see Ebola in West Africa. We knew of Ebola, but we did not expect it to see them. So of course, I do think that wastewater surveillance is actually the future to solve a lot of these issues, especially as it comes to surveillance gaps across multiple different pathogens, but also to allow us to get additional information about these pathogens. And there are many reasons for this, but I just want to mention one key reason to why I think this is so important. And it is because it actually, in terms of implementing, it is akin to passive surveillance, where you monitor in hospitals, but you're not actively looking for cases. Here, you're just doing it in wastewater, right? So that is passive surveillance, but it really is active, because if you have these infections in the community, even if you did not know about them because you had not seen the cases yet, wastewater is able, at least for a lot of them, to detect them before you realizing that you see patients coming up. So this passive surveillance that is active in the way it works is the reason why I'm in love with wastewater surveillance, and why I actually think it is the future of how we do a lot, although not all, of infectious disease surveillance. Now, my group has been focusing on, especially during the pandemic here, software development as well as technology development. On the software side is really a lot of the stuff that we are focused on. On one side, things like outbreak.info, which is a website that we try and visualize data. Now we have wastewater surveillance data for SARS-CoV-2 on there, but trying to visualize data streams that are public to do visualizations and analyses that are actually helpful to the public, whether those are just the general public, the public health community, or scientists as well. Freya might be one of the ones that you guys know about, which is a way in which Josh here has developed, and Mary and others are working on to further develop it, is to take genomic surveillance streams from things like SARS-CoV-2, but also other pathogens now, to try and understand which variants and lineages you might have of SARS-CoV-2 in a wastewater data stream, or an environmental data stream, or milk sample if you're talking about H5N1, because these are inherently mixed samples. Now, one really key aspect of our work, though, is that while we are located in San Diego, and most of what we do is in San Diego, with a lot of collaboration with the San Diego public health community there, HHSA, for example, is that we really do think a lot about what's possible in San Diego really should be possible anywhere else. And here's just one example of this from one of our early papers, showing where Rob Knight's group, for example, plastered the whole of UCSD campus with autosamplers, and then we do surveillance across the entire campus, which is very impressive, and it's hugely useful. Also in the middle here, the central wastewater treatment plant in San Diego, and incorporating it here. But then really importantly, also with our partners across the world, here's one example from Malawi, for example, where here you don't have wastewater treatment plants, but that doesn't mean that you can't continue to do wastewater surveillance. Here, you're just using streams and standing pools of water, of course. So for us, this is really key. So everything we try and develop, ultimately, we want to see incorporated into that setting. Now, some of the main things that we're focusing on right now, and again, this is Josh leading this work here today, so come talk to Josh, but it is to integrate wastewater surveillance at scale. And when I'm saying integrating, it's integrating it with other data streams too, epidemiological data streams, clinical data streams. Of course, expanding to new pathogens, as we're talking about genomics, both from the technology perspective of developing the protocols, but also importantly, developing the software so you can meaningfully analyze them. And then also integrating and improving wastewater surveillance methods, because SARS-CoV-2 is pretty easy. You have a lot of data, you have very nice genomic data, you can probably sequence it with pretty much anything, but that's not true for many other pathogens like flu, and others is much harder. You might also use a MinION platform, but you would use an Illumina platform, for example, and being able to do this across platforms is really key. Now, just one example of how we then do this. You've all seen this, right? But here's just an example of how well on top here, wastewater surveillance, and we're looking at SARS-CoV-2 lineages over time, tracks that below, which we can then retrospectively do for clinical sequencing. And really, it just shows you that, well, whenever you see in wastewater, at least as we're talking about SARS-CoV-2, really tracks very well with what you are seeing in clinical samples. And importantly, working with partners across the globe, we are also trying to show how you can do this at national levels, not just here in the United States, but also across different partners and across different countries, covering most continents. And here's just one example, again, showing just SARS-CoV-2 lineages. For now, it's focused on SARS-CoV-2, but can be done with very many others, just comparing what you can see in clinical versus wastewater across the multiple different countries. And importantly here, you can see the lineage dynamics of something like SARS-CoV-2. We can allow it to ask new questions like, how does that lineage dynamic start in one place and then you see that spreading to another place, something which we have seen with flu dynamics. And the question is, how is that going to play out with SARS-CoV-2? A really key aspect, though, when I talked about these surveillance gaps, the delay in detecting a pathogen that you may or may not realize you have in the community, showing how much sooner you can do this with wastewater. If you just look at this plot here, you can see everything on this side means that you detect it earlier in wastewater, and everything on that side for different lineages here is that you detect it earlier for clinical. And now, typically, you detect it much faster in wastewater, and this is especially true if you don't do a lot of clinical detections. During the pandemic, of course, people did a lot of sequencing on the clinical side, right? That is no longer the case. So the less you do that, the earlier you're going to be able to detect something in wastewater. Now, as I mentioned, expanding to new pathogens really is a key aspect here. And the question is, how do you do that? Well, you prioritize them based on public health impact, emerging, endemic, novel, unexpected, and then have a normal standardized ways in which we can annotate these pathogens and their lineages, and then incorporate them into a set of barcodes that you can then use with something like Freya to get your meaningful analysis. And we are now doing this with a large set of partners, and again, focusing on many different pathogens. Some of the key ones we are focused on, Ali just talked about measles, for example. We can actually also sequence measles. We work with our partners at NICD in South Africa to show that you could do not just measles detection, but you can also do measles sequencing directly from wastewater. And then you can use things like Freya to actually analyze your output to understand which subtypes of measles you might have. Of course, the vaccine strain is one thing, but everything else that might circulate in the community. Other things like Mpox, where we have also had to develop a sequencing scheme because Mpox is very big. There's not very much of it in the wastewater, right? It's about 200,000 base pairs versus about 30 for SARS-CoV-2. So being able to sequence Mpox and get more information about that, you can't do full genome sequencing because there's just not enough material. So we're doing this focused sequencing where we're saying, what are all the important mutations in Mpox that we want to follow? And then we have a scheme for doing that. And then importantly, analyzing it with Freya downstream from there. Also things like tuberculosis, hepatitis, influenza, and others are also where we have schemes, and you can get all of these from our website. So with that, I just wanted to thank, we have a huge set of collaborators here, especially Search and Prevent. That is our local collaborations. I could see Seema is over here sitting representing San Diego here. I had a tremendously good collaboration with San Diego Public Health during the pandemic. And then, of course, my lab and in La Jolla, I'm basically just the emailer in chief. These are the people that actually do the work. So Josh is here and Mariam is here, as I'm saying, and doing a lot of the development on the wastewater side. Thank you.
All right. Thank you so much, Christian. Up next, we're going to bring our next virtual speaker. It's going to be Kirsten Weisbeck. Kirsten is the Wastewater Surveillance Data Analytics Supervisor at the Colorado State Department of Public Health and Environment, and she'll be presenting on advances in mobility data. And I just want to double check, Kirsten, can we hear you?
I hope so. Can you hear me?
Yes, we can hear you clearly. All right.
Thank you, Stephanie. Good morning, everyone. As Stephanie said, my name is Kirsten Weisbeck. I'm the Wastewater Data Analytics Supervisor on the Colorado Wastewater Surveillance Team. And I'm very excited to share some recent work examining mobile device data in Colorado to hopefully help us understand wastewater surveillance metrics more broadly. So wastewater surveillance data experts continue to work on converging on metrics and data visualization approaches to improve the general interpretability of wastewater surveillance data for both existing and emerging targets. Factors that affect interpretation include the number of people contributing to a sewer shed or wastewater sample, environmental factors, wastewater treatment plant infrastructure, and variable shedding rates. In this analysis, we primarily focused on the variability introduced by the number of people contributing to a sample. So at present, a common approach to account for population fluctuations in a given sewer shed on a given sample collection date is to normalize the viral concentration, or essentially calculate a viral load to improve the comparability between utilities. Metadata for each sample, such as flow rate or microbial factors like PMMOV, CRAS phage, other human DNA analytes, are often used to normalize the viral concentration for a given sample. And wastewater flow rates have the potential to capture these fluctuations, but they may decouple from population dynamics when there are large industrial discharges, large weather events that lead to infiltration, or other factors. Cell phone-based mobility data presents an alternative method for estimating population fluctuations with the potential to capture more granular, short-term patterns like weekday versus weekend movement, as well as longer-term trends. For the sake of time, I won't go too deep into this, but there is a growing body of research evaluating different normalization methods. And in a lot of cases, the different normalization factors do support close alignment with clinical cases, at least in analyses looking at SARS-CoV-2. However, all of these different factors do have different limitations in terms of how they decouple from true population dynamics. We decided to look at flow rate because at present, this is one of the most common approaches to normalization. So our key objectives were to first evaluate mobile device data to characterize fluctuation in populations in Colorado. And then we also investigated the relationship between mobile device counts and flow rates. And one thing that's important to note is that in our program, we currently use a Sentinel system, which includes 20 utilities. And we, in this analysis, examined as much historical data as possible to ensure that this could also in part inform our emergency surveillance system efforts as well. So our key questions here are really, do mobile device counts and flow data capture population fluctuations in sewer sheds over short and long timescales? And then to what extent do device counts and flow rates agree? And when and where do we find the greatest and least alignment? And then of course, can we explain any of the decoupling between device counts and flow rates? So this is a map of our sewer sheds with the Sentinel sewer sheds in maroon and our historical, now emergency surveillance sites in this gold color. So we of course had to use our spatial data. We also used mobile device data sourced from AdVan via DEWI data. And then we also used a sewer shed flow rates sourced from wastewater sample metadata measured in millions of gallons per day. There was extensive work done in the spatial methods department to assign device counts based on their overlap between census block groups and sewer sheds, which, as you may know, is not a perfect science, but we did as much as we could to reduce the possibility of duplicate device counts and reduce our assumptions about the overlap between census block groups and sewer shed areas. A k-means clustering algorithm was used to characterize fluctuations in device counts. We also tested non-parametric rolling correlations between flow rates and mobile device data. And then we are currently working on a regression analysis to examine the relationship between environmental factors, flow, and mobility data. To share our initial findings, first and foremost, the k-means clustering algorithm uncovered two very distinct groups of mobile device fluctuations in Colorado, which we're calling high and low variation sewer sheds. So for the vast majority of our sewer sheds, these cluster assignments were aligned with what we would expect with some of our qualitative knowledge about Colorado. So high tourism areas largely aligned with the high variation sewer sheds, and then more metropolitan, suburban, lower tourism areas aligned with lower variation sewer sheds. Let's see here. And then when we looked at day of week differences, high variation sewer sheds tended to have higher device counts on Fridays and Saturdays, with low variation sewer sheds having decreased device counts on Saturdays and Sundays. And then to examine the mobile device estimates and flow rates, we performed a rolling correlation test for 65 Colorado sewer sheds with a non-par roll core R package using a daily time step. So we calculated the mean rolling correlation coefficient for each season and year, and then stratified that by high and low variability. This example is just one utility, but it shows relatively good correlation over time, though as you can see, the strength of the association is pretty variable with some periods of a lower strength correlation. And again, this is just one utility. These associations varied quite widely between utilities. We calculated the rolling correlations for each individual sewer shed and then ranked them by strength to assess the strength and stability of each sewer shed's flow and mobile device relationship over time. Sewer sheds were ranked here according to strength on the graph on the left-hand side for the percent of rolling correlation values at or above 0.5. And then when we look at this, this shows that the many high variation sewer sheds showed a strong correlation between the device counts and flow rates, although this was less stable when we looked at this on a seasonal basis. All right, and so our high variation sewer sheds showed a substantial decrease in device counts in April and May. A lesser degree of population shift was indicated by the flow rate data. And just to orient you, on the left-hand side, we have high and low variation sewer sheds per mobile device count data. And then on the right, we have our flow data. And I think what's also interesting here is in January through March, leading up to this drop in population, there's a decreasing pattern in the mobile device data, whereas with the flow data, this shows an increasing trend leading up to April and May. So where does this bring us with wastewater surveillance metrics? We've learned that device counts and flow rates are inconsistently correlated over time in between sewer sheds. Device count and flow rate correlations were lowest in April and May, springtime in Colorado, which is synonymous with periods of higher snowmelt and potentially higher inflow and infiltration. And then also trend model adaptations may be warranted to account for the decoupling of flow rate and population movement. And this might improve the utility of our data. So there are, of course, limitations and important considerations to interpreting these results. Mobile device data is presented at the census block group level, which imperfectly aligns with our sewer shed boundaries. A single device may move through multiple census block groups, so between sewer shed comparisons may be limited due to some duplicate external device counts. Also, we can't assume that just because a device moves through a sewer shed that it's equivalent to one person contributing to a local sewer shed. Device counts can also be affected by location tracking opt-in rates, and flow data isn't always consistently reported for each sewer shed area. So our next steps are to integrate clinical data to evaluate the relationship between normalization methods and outcomes for various targets, and then also to integrate more environmental data to understand the degree of influence of factors like precipitation and temperature on flow rates. And then finally, we also are integrating alternative sources of mobility data like traffic pattern data to further evaluate the relationship between population movement and flow rates, and moreover, the diffusion patterns of key targets in wastewater surveillance. And with that, I would like to say a major thank you to our partners at the Colorado School of Public Health, Emma, Andrew, Beth, and Teresa for their support and enthusiasm for this project. Thank you.
Thank you so much, Kirsten. I guess I have to advance through the slides again. Is that? We're going to get there. Don't worry. All right. Our next speaker is also joining us virtually. I'm going to introduce Dr. Emily Nightingale. Emily is a statistical modeler and assistant professor at the London School of Hygiene and Tropical Medicine, and will be sharing about advances in modeling. Emily, are you available?
Yes, I am. Hi, can you
Wonderful.
hear me?
Yes, we can hear you
able
too.
Are you able to see my screen as well?
Yes, we can.
Fantastic. Thanks very much. So yeah, my name's Emily Nightingale. I am a sort of statistical modeler / epidemiologist at the London School of Hygiene and Tropical Medicine. For the past few years, I've been working on polio eradication, and sort of that's the direction through which I got into the space of wastewater surveillance. So I'm going to be talking a little bit about modeling approaches that integrate wastewater surveillance data. So the context that I work in, polio, is an example of where just the presence of pathogen in wastewater is enough to trigger action, for example, vaccination activities and enhanced surveillance. And similarly with an emerging threat that we've seen in the last few years, like COVID and Mpox, we've seen, and also linking to what Christian was saying earlier, we've seen that just simple analyses of time series of wastewater data, looking at increases and decreases in trends, provides us a lot of valuable information for decision making. There's often a signal in the wastewater a lot earlier than in clinical detections. And so just this begins by illustrating that wastewater data have significant value on their own. However, the interpretation of those raw data is not always very clear cut. And so the role that modeling plays is to provide a framework for consolidating these potentially noisy and ambiguous signals and discerning when we need to take action. So yeah, how many infections could this represent if we have measured a certain load in the wastewater? What if the surveillance streams are conflicting, and when do we actually decide to trigger action? So as I'm sure we'll see a lot of detail from different speakers on the different components of wastewater surveillance over the next few days, the overarching point is that it's a very complex process and a lot less well defined than more traditional surveillance mechanisms for sort of constructing a model of it. And the approach that we then need to take to modeling this complex system depends on what aim we have, what sort of question that we're asking of the data, whether we are targeting just an early warning trigger or understanding future outbreak risk, interruption of transmission. For these different questions, we may need to think about shedding profiles, frequency of sampling, dilution, possibly degradation in the environment. And all these components may be unique to the specific pathogen and setting that we're looking at. So we need different approaches, and we need to sort of, to a varying degree, incorporate detail in these different components of the process, depending on what our question is. But in most cases, we don't have the data to define each of these moving pieces. So we need to make some judgment as to what aspects are important to define explicitly to answer the question we need to address, and what may instead be simplified. And this also raises a higher level question as to whether the models that we're using to interrogate wastewater surveillance data need to be just bespoke to a particular context, a certain pathogen setting or a water system, or whether there's scope for more generalizable frameworks. So I wanted to talk quickly about one particular example, which I think is a nice example of demonstrating the real value of incorporating wastewater surveillance data into what's here a mathematical model of transmission dynamics. And in this case, it allowed the authors, Brower et al., to interrogate the evolution of an outbreak of poliovirus which was otherwise silent. So no clinical cases were reported, but retrospectively, based on the data in the wastewater that was being routinely collected, they were able to reconstruct the dynamics of this particular outbreak. And this kind of analysis provides really important insight into the near elimination dynamics and outbreak potential of polio in this context that wouldn't otherwise be understood without the use of that wastewater. So in that critical period towards the point of elimination, where clinical cases are no longer representing, giving us enough information about infection dynamics. So in this particular model that they incorporated a lot of detail about the contribution of different shedding profiles according to immunity levels, which these two figures in the top right. But on the other hand, didn't explicitly account for other elements of the process. So, for example, elements of the sampling process or how multiple sites that were included may represent different catchment populations. So that's a sort of a balance that they took there in terms of the complexity of the modelling. In contrast, some of my own work around polio has focused on a different part of the surveillance process. So not thinking about outbreak dynamics, but instead asking at the other end of the spectrum how confident we should be about the absence of polio in collected wastewater samples. So the model that we sort of constructed for this here on the left reflects the steps with which an infection is captured in wastewater surveillance. And our goal was to aim to quantify the sensitivity of detection of wild poliovirus if it were in fact in the population. And this ultimately would help us interpret the information that we have from wastewater, in particular in periods of time where no samples are testing positive. So a fundamental point in this particular question is that negative samples don't mean the same thing at different times and places. We've seen that also from Christian's presentation just before. We're capturing different people and different information in different times and places. There's a lot of reasons why, based on the heterogeneity of the wastewater surveillance system across a broad region, why the sensitivity of detecting polio would vary. So this was something that we aimed to incorporate in this particular modeling task to estimate a variable sensitivity of the system to detect wild poliovirus, which shown here for the time period above, so just over time, not over space, but there was spatial heterogeneity incorporated into this as well. But to achieve this, we had to make a lot of assumptions as to how the different factors that we assume influence sensitivity, like quantitatively affected sensitivity. So without an absolute measure of underlying prevalence, we can only quantify relatively how well the system is performing in this instance. Oops. So a solution to this problem, which I think has been touched on earlier, is to consider something more common, which may be detected in the wastewater, for which it's possible to actually estimate an underlying prevalence and create a benchmark against which to evaluate the wastewater surveillance system. And in the case of the polio system, we looked at non-polio enteroviruses, which are expected to be present in the population, and we can estimate their prevalence from other reported clinical data, which provides us with this benchmark. We've got some, this is an illustration here just of the variability in the detection of non-polio enteroviruses over time and space for Pakistan, which is what we're looking at in this case. So the question that we pose is, what drives this variability, and how much of that variability is due to epidemiological differences and how much is systemic? And the idea is to try to ask this in the case of enteroviruses, which are more prevalent, easier to predict, and then take our conclusions into interpretation of the polio data. So more recently, I've been working on modeling this relationship between expected underlying enterovirus prevalence and how and where it's detected across the wastewater system, so we can understand a bit more about what drives this heterogeneity between sites. So hopefully by modeling this sort of connection between the sort of map on the left and then the point observations on the right-hand side, we can better interpret absence from particular sites, given what we know about that site and how strong the detection of these type of viruses is at that location. And potentially, we also may identify factors that could be modified. So prioritizing certain site locations, positions, or types of site in order to improve the reliability and consistency of information we've got across sites. So I'll sort of skip over this bit because I think it has been mentioned before, but obviously enteroviruses are one example, but there are a lot of different benchmarks which have been explored in different contexts. And I think there's a sort of interesting area there to sort of understand comparatively how useful each of these different benchmarks is for measuring the sensitivity and the sort of strength of a wastewater surveillance system, and definitely scope there to look at ways of standardizing to make to improve the sort of comparability between wastewater surveillance systems in different locations. Oops. Can't progress. There we go. So a question that I've come up against a lot in trying to address these problems is around who in particular is represented in wastewater surveillance. We've talked about this before, but there are a lot of different sort of ways conceptually we can think about modeling how the value at a particular site, the collection site, is representative of the surrounding population. From a spatial modeling perspective, we may have defined boundaries of catchment areas based on the formal sewage structure. But we may also use simpler approaches, thinking about proximity. So just it represents the population within a fixed radius or a radius with some sort of decaying correlation. But in particular, what's interesting about modeling wastewater surveillance is the asymmetry in this. So water flows in one direction, and this is a relatively novel area, I think, in the area of spatial modeling, of representing correlation, which is stronger in one particular direction versus another. And that's, I think, a gap that we may be able to fill in between the problems we're facing in wastewater and the sort of development of statistical methodology. And then on the other hand, how in particular does this representation differ between surveillance streams? So this is central to the integration of multiple surveillance streams and making the most of all of the information we have available to us to interpret where disease burden is across a population and where to target interventions. So the connection between how we model the surrounding population and then interlinking that with the units at which we have other data sources like clinical cases. So in summary, the modeling that we can do with wastewater surveillance data allows us to extrapolate from those raw observations and take public health action, which sort of goes beyond that just initial detection and early warning trigger. But wastewater surveillance is a very complex system, so we need to be quite thoughtful as to where we put that complexity in our modeling approach and think about which elements of the process are most relevant to the particular question that we're answering. But personally, the use of the measurement of benchmark indicators, I think, should be really, we should work on standardizing that and making sure that if we're going to implement wastewater surveillance, we're collecting these kind of alternative measures so that as we're collecting data, we are able to evaluate the system against such benchmarks. And so characterize heterogeneity in the system in order to distinguish this from heterogeneity in the epidemiology, which is what we're trying to actually understand. Okay, thanks very much for listening. Just some acknowledgements, Kathleen O'Reilly and Caitlin Johnson for their input on the slides. Yeah, thank you very much.
Thank you so much, Emily. All right, I'm going to bring up our last and certainly not least presenter to come up and join us. It's Dr. Heather Bichelle. Heather is an associate professor of civil and environmental engineering at UC Davis, and we'll be talking about advancements in laboratory methods. Hi, everyone. Nice to see you all. So I'll be talking today about a project that we've been working at UC Davis over the last couple of years in collaboration with UC Berkeley and Lawrence Livermore National Lab, led by my postdoc, Wenting Lee. So we've seen in the first few presentations, of course, that PCR is the gold standard for pathogen quantification in wastewater and trend analysis. By the corollary with substances and chemical exposures, targeted mass spectrometry is also a gold standard to reliably and sensitively monitor chemicals at very low concentrations in water and wastewater systems. And these are targeted and specific, quantitative for trend analysis, established and widely available. We heard from Ali and the extension and multiplexing, which we need to know information about pathogens in advance, and but you can build those on one by one into a multiplexing system. And then we heard about sequencing as the growth of complementary information from genomic surveillance and the additive information you can get about strains from sequencing. By the same token, with targeted mass spectrometry, which looks at spectral signatures of chemicals, we have non-targeted data acquisition for high-resolution mass spectrometry looking at more chemicals. Our group in this project, we decided to start to look at an opportunity around wastewater proteomics and using mass spectrometry for the detection of peptides associated with different viral proteins. So like PCR and mass spec for small molecule analysis, proteomics has targeted applications where proteins are digested into their peptide components, and you can detect those on a one-by-one basis. We decided to look at a shotgun or non-targeted type approach in the lab to assess many types of proteins in wastewater. And specifically, we wanted to look at benchmarking the detection of SARS-CoV-2 derived proteins so that we could then enable potential extension of wastewater proteomics to other biomarkers because there are a range of potential complementary applications of proteomics. So as part of that, we worked to try to distinguish variants of SARS-CoV-2 based on their amino acid sequence differences using spiked in or added spike proteins and whole viruses spiked into wastewater. And then we also looked at the quantitative potential for proteomics using this mass spec or MS signal based approach. And we heard about normalization factors, right? We know that there's a lot of different options for that. So we wanted to look at the effect of normalization factors that were within our non-targeted data acquisition in the proteomics analysis. So I won't go into detail into our method development process. Unlike sequencing and PCR for wastewater, which is a relatively mature field at this point, mature in the especially with all of the advancements in the last several years, there's a handful of studies that have been looking at applications of proteomics in a wastewater setting. And so we use those experiences to try to work on increasing our yield of peptides in analysis, reducing interferences from all of the complex molecules in the systems, evaluating different instruments, and evaluating different data acquisition methods. And we settled on a method. For this study, we collected wastewater from the UC Davis wastewater treatment plant, which is convenient nearby. We're working on extending our geographic analysis coming out of this project. But we filter influent wastewater, and then we looked at a concentration method for keeping retentate with ultrafiltration, which we use a S-trap type proteomics digestion protocol to get peptides in that concentrated fraction. We also looked at the filtrate of our ultrafiltration membranes to try to see if there were pre-digested peptides with lower background signals that we could differentiate from that more concentrated retentate fraction. And we add internal standards to the mix. And then we also collect or do data acquisition in a couple of different ways to get complementary information. So we use each sample is analyzed in data-dependent acquisition mode, which takes higher abundance spectral features and fragments them to look at good identification of the peptides that are in place. And we also do a data-independent acquisition mode on those same samples that facilitates extension to new targets because it takes all of the peaks that you see and fragments them. So you get kind of a more complex spectral signatures, but also then allows us to go back and look at the data set that as we develop, better libraries for looking for different types of peptides, you can use that data that you've collected to extend beyond the more targeted high abundance peptide markers. So in terms of our validation experiments for this method, we used a series of recombinant protein standards and some inactivated whole virus standards to work on this variant differentiation and benchmarking approach. So one of the challenges in looking towards potential quantification, of course, is getting calibration curves. So we evaluated dilutions of S proteins using a suite of recombinant protein standards. For any given protein, we can detect a bunch of different peptides, right? And not all of those are going to be unique to a single variant. So for those sets of peptides that we detected, we established some linear calibration curves that help build confidence in our ability to quantify off of these data sets. And we internalize those with heavy peptide standards that account for ion suppression and enhancement in the samples. And then in some additional spike-in experiments, we were able to show that it's feasible to differentiate amongst variants through detection of specific peptides that are unique to the proteins that we spiked into the wastewater. So feasible with the method that we were working with in spike-ins in the wastewater at the concentrations that we spiked in. We also wanted to look at sensitivity for the protein detection spiked into wastewater. And we did this using N protein spike-in. So the last slide was looking at variant differentiation using the S protein, where a lot more mutations take place in the virus. When we analyzed our wastewater, we also had more background of S proteins that we were detecting. So we switched and we're also looking at N protein to assess the sensitivity and the quantification of the method. So the method here gets results more in mass per volume as opposed to genome copies per volume. And it is less sensitive at the levels that we were looking at relative to what you can get from PCR and the amplification of the signal. But we were able to detect these two different types of proteins in the wastewater. So extending that method, we're looking at how we can quantify both N and S peptide levels, and then compare that to results for the same wastewater samples analyzed through ddPCR, looking at N gene measurements normalized by PMMOV as our PCR-based normalization factor. So this plot shows our peak area normalized by our heavy internal standard for N proteins in the lighter color and S proteins in the darker color here through a 14-day sampling period that we were monitoring. And we saw that the S peptides that we were detected were on average more abundant than the N peptides in the wastewater. We had one high abundance unique peptide that aligned with the XBB 1.5 variant. So that was interesting to us because we knew that the dominant variant circulating at the time of our sampling was JN1. So this gets at kind of the challenge of variant differentiation in practice with the method that we were working with, where we did detect a unique peptide that we suspect could be from a vaccine-derived peptide from the COVID-19 vaccine that was widely used at the time. So we decided to then focus on the N protein peptides for quantitative assessment to differentiate what were necessarily proteins derived from the circulating virus. So one of the benefits of this non-targeted peptide data acquisition method is that we can look for many other things in the wastewater at the same time. So in that 14-day sampling period, we identified 15,000 peptides that corresponded to 5,000 distinct proteins. And that was using a database from the Swiss PROT database, which has nearly 600,000 sequences in it. We also supplemented that database with spectral signatures from our SARS-CoV-2 standards so that we could look more specifically at the data for those compounds. So we did see an increase in the yield with the method that we applied compared to what was available in the literature so far. And we wanted to then identify in situ normalization factors that we could use for normalizing our mass spec signals. So we had 262 human proteins detected with at least one unique peptide associated with it. And we wanted to look for peptides that were high abundance, high frequency, and relatively good coverage of the protein of interest. So we identified 3 proteins: maltase, glucoamylase, pancreatic alpha amylase, and alpha amylase 1B. So each of these 3 proteins we then tested for normalization of mass spec signals relative to our ddPCR signals. So one of the validation experiments we did was spiking in our virus peptides, taking out peptide abundance from the background and comparing correlations between just the spiked in different peptides that we detected in different samples and with and without normalization. So without the normalization of our SARS-CoV-2 peptide signals, we had relatively poor correlation, and then we add in a normalization factor from these in situ spikes, and we could see some improvement of the signals with those different normalization factors. So this was promising to us that we did see some improvements there. And then looking over that 14-day sampling period, we compared the N protein signal normalized by each of the proteins. This one's alpha amylase 1B compared to the N gene measurement normalized by pepper-mild model virus. And again, we saw some improvement of the MS signal normalization correlation coefficients relative to the MS signal without normalization against the ddPCR signal. So we did see this improved correlation relative to PCR-based measurements. Overall, we saw this increased peptide yield relative to previous studies. We were successfully able to test mass spectral signal normalization factors within the data that we collected. There's a wealth of data within these acquired spectra that we can also look back at other proteins and other viruses that are present. And we were able to see a relative abundance difference in N and S peptides, although we did have difficulty in having variant identification and differentiation within the samples. And then we benchmarked the N protein quantification against our N gene measurements, which was promising for us about the ability to use mass spectrometry and proteomics in a wastewater context. So as I said, a lot of this work was led by my postdoc, Wen-Ting Li, and we worked closely with Carolyn Fisher at Lawrence Livermore National Lab and the UC Davis Proteomics Core Facility with Gabriela Grigorian. And also this has been taking place in the context of the Preview project, which Rose Cantor was our project manager through this and really led our team all together with the collaboration. All right, I just want to say that those have been incredible presentations on various topics. And so we're hoping to kind of bring that all back together and spend a little bit more time digging into each of those topics. We're going to open up our Q&A session. We actually put a lot of time to our Q&A session, so we hope to have everybody come up and ask your questions. We also are helping to field questions from our virtual audience. So we have our speakers up here. We have our virtual presenters ready to go. We have a microphone in the middle for our in-person audience to go ahead and come on up and ask your questions. I believe Carly in the back will be, oh, are you mic running or is that? She is going to ask the online questions, so she'll be monitoring the chat for those. I will say, if you are in person, please announce your name and affiliation so that our virtual audience knows where you're from. And also, golden rule of hybrid conferencing: if you don't have a microphone, we can't hear you. So be sure to speak into the mic. Same with our presenters as well. Oh, we can bring up the virtual. Yep. Yeah, absolutely. I'll let Anna do this.
Yeah, but go ahead, ask away.
Hi. So my name is Prakit Singh. I am the APHL fellow from Hawaii Department of Health. I think my question probably to Dr. Alexandria Beam. So a part of my project is to help the state lab develop the testing on new target like the CRS. But throughout my preparation and study, I have learned that the targets like CRS, and maybe it also applies to like antimicrobial resistant genes as well. There are currently there are limitations of we know very little about shading rates, and also the sources of target like CRS can be from multiple places. Like it can be from colonization cases and not infection cases. And people also talk about like maybe they are from biofilms in the pipes. And these questions people might already raise in the past. So I want to hear your opinion about if there is any updates on this and how to address this, or do you have visions on how are we going to deal with all these while developing the test for the target like this? Like to you and maybe other speakers, if you have some information to share. Yeah, thank you.
So am I allowed to answer without a mic? Yeah, that's a great question. And I remember when we published our CRS paper, we had similar comments from reviewers. And so I guess I have like a philosophical answer and then like a technical answer. The philosophical answer is that it's really easy to cast doubt on anything by saying anything you want. So anyone can say anything, and it's like, do they really deserve all this attention if there's no evidence to support it? So like, what if it's from a dog? What if it's a biofilm? Well, what if it's from the moon? Like, there's no evidence to support that, right? But like so it's like speculation, but also like, so that's my like philosophical answer, is just to remember that it's really easy to like say all the reasons why it may not be true that you actually detected it, but like you did detect it. So, anyone can cast doubt on anything. So keep that in mind. And then I think the technical answer is to, you don't want to, as a scientist, you want to always be skeptical. So you want to acknowledge the limitations of your work. It doesn't mean you shouldn't do it, but just put them clearly, describe them to people. So like in our CRS paper, we said, yes, like we looked and it is possible that this could grow in biofilm. And, there's like one paper that detected a Candida strain in a biofilm, but they didn't confirm it with CRS. And so it's possible, but it doesn't mean that we shouldn't be doing this work. And then in terms of other sources of the pathogen, I think, viruses are pretty easy, so to speak, because we know that which viruses infect humans and which ones don't. But when it comes to bacteria and fungi and other eukaryotes, they do have animal hosts. And so it could be that you're detecting a zoonotic infection that got into the wastewater. But, that's actually important too. Like we do need to know if there are zoonotic infections from, pathogens that can make people sick. So that is potentially useful as well. And I think we were really surprised that H5 could be used in wastewater to actually track zoonotic infections in cattle. So, that might actually be a virtue as well. But I think, most of the success with wastewater surveillance has been with viruses, and doing bacteria and fungi are more and more tricky because of the complexities associated with virulence genes and the specificity and sensitivity of different markers to virulence versus the actual bacterial pathogen. So I think I don't have like that's sort of my answer to your long-winded answer to your question. Yeah,
Oh, no,
I hope that's helpful.
Yeah, yeah, perfect, helpful. Thank you.
Yeah.
All right, we have a question online that was actually answered. So I'll state the question and the answer so folks in the room can benefit from that. So there was a question about what was the source for the Colorado mobile data? And Kirsten answered, it's Advan via DEWI data. And then there was a question of how much does that cost? And she doesn't have an estimate right now, but her best guess is several thousands of dollars.
All right, thanks, Anna. Prabhu.
Great. So my name is Prabhu Gounder. I'm with LA County Public Health, and we're on the end user side of the wastewater data. So trying to figure out how to correlate it with our clinical surveillance data and how to interpret it. So that was one of my questions, as well as what's the source of the mobility data. But I also had another question for Kirsten, which is, have they thought about how to use it to attribute cases to different sewer systems for cases that are not common and have long shedding periods? So I think for SARS-CoV-2 it probably doesn't matter because there's so many cases and it's a relatively short shedding period. So it probably evens out when you're trying to correlate. But Candida auris is a good example. These things that are colonized for a long time, or currently we have a hepatitis A outbreak where we think the shedding period's maybe 3 weeks. And right now our simplistic model is to assign it to a specific sewer system, but we know people live and work in different places, and trying to figure out how you account for that in your correlation. And I think the mobility data could be very useful for that. And just wanted to see if Kirsten has thought about it or done that work already for some of the pathogens and trying to figure out how to attribute cases to sewer systems.
Thanks for that question. The short answer is no, we have not done this yet, but it is definitely on our radar. I think that we talked about this a bit in various presentations, but with the limited data on shedding dynamics, it can be a bit tricky to layer that on top of our gaps in understanding on population movement as well. I think my first step in sort of where we're going with this is to first use what we've learned from this in terms of high and low variation and apply that to the windows that we're using to calculate trends. Like, for example, higher variation sewer sheds, perhaps it would be better to use a shorter trend window given what we know about the population dynamics. I think also what we want to use this data for is sort of diffusion dynamics and looking closer at these different clusters, so that if we do have a detection and maybe can't make certain assumptions about viral shedding, we at least have some idea of how trends move spatially.
Thank you.
Hi, my name is.
Sorry.
So
We're
sorry.
going to
can
ask
go
an
to
online.
virtual.
Sorry to interrupt you. So this one is for Heather. Heather, are there any particular chronic diseases of interest where you would hope to apply your methods?
Is this working? Oh.
This one is.
Maybe? Oh, yeah. Thanks for the question. I think that's one of the things I'd love to get input from the audience here, and to Ali's point in terms of, what targets to be looking for and spending our time working on, is to hear from you all about what you think may be particular targets of interest. For us, it was an interesting finding to be able to look at a potential for vaccine shedding of, these mRNA type vaccines and the persistence of those. And we're also extending to look at more virus inactivation mechanisms and expression of proteolytic enzymes, for example, in an environmental engineering context. So I'd welcome, feedback and ideas from folks as we start to delve deeper into this data set. All right.
Awesome. My name is Sophie. I'm with California Department of Public Health. And my question is for Christian mainly, but happy to take answers from anyone. I was particularly interested when you mentioned sampling, I think it was in Malawi, for places that don't even have a wastewater treatment site. So I was just wondering if you could speak a little more broadly to the use of wastewater surveillance in lower middle income countries for surveillance.
Yeah, so, okay, it is,
It's working.
At least it was working. Yes, so, in those sources, again, you don't have the wastewater treatment plants, right? So you end up using either streams of water in which you have a flow going, or you use standing pools of water, which you might have pooling. Of course, it matters in terms of the quantification if you have flowing streams or you have pooling water, for example. But the idea there is that you do grab sampling, so not auto samplers, of course, so just grab sampling. You take that back to the lab, do the normal separations, and then you do, again, both PCR, for example, to detect the pathogens as well as sequencing. And we, in Malawi, is a good example in which you use the whole, because you, again, it's grab sampling, it's standing pools, and it's streams. And it works pretty well. Even the longitudinal data of SARS-CoV-2 lineages, for example, looks pretty reasonable compared to more consistent sampling. South Africa is a different example in which you do have wastewater treatment plants, but it's still grab sampling, right? So you only go in and grab once, and then you take that back to the lab. And of course, it gives more variability than an auto sampler will do, for example, but it still allows you to get pretty much the same picture in terms of burden and certainly in terms of the genomics of that. So really can be used in very low resource settings.
Are you able to sort of define a sewer shed still in these areas that don't have a wastewater treatment plant? For example, like
Yes,
a
so Josh and I just went to South Africa and driving around to the different sampling places, and they are different. Like some of them are outside, barracks, for example, others are outside hospitals, and others are at the treatment plants themselves. I can't remember how many collections. Is it about 50, Josh, or so? Across the country, yeah, but we have like Gauteng province, for example, there's a lot of different sheds, and in general, they are in agreement, although of course the data is noisy, right? So it takes a little while before you get a good signal locked in, but you can certainly see early trends still.
Thank you. All right. Doesn't sound like we have a virtual question, so we'll go right here.
My name is Kirsten St. George. I'm from the New York State Department of Health, and my question is, I guess, directed at Dr. Anderson. And it's a follow-on from the first question that we had in this series. Certainly I understand that there's plenty of naysayers in the field, and it's very frustrating when you work in wastewater and you get that sort of negativity. However, Canada has been shown to colonize sewer lines and complicate the data that we get. And this is outside my area because I'm a virologist, so what I know about mycology is very limited. But it's my understanding from my counterpart director in mycology that the Candida species that do that evolve differently in the pipes. And if you sequence, you can distinguish between what came out of the pipe and what came out of the hospital or patient or so on. So I'm wondering if there are any efforts to sequence from inside the pipes in biofilms that are colonizing the pipes and the lines in not just Canada, but other organisms as well, so that we can distinguish between what is actually coming from colonization of the sewer line pipes and what's real sort of effluent into the water.
Yeah, so that's probably a shared question between Ali and myself. So we have not done anything for Canada specifically or non-viral pathogens. And I don't know enough about the diversity of Canada to answer whether you can do that in principle. But we can do, methylation patterns, for example. That comes back to the question of zoonosis versus human too. Methylation patterns differ depending on which organism that in which host that organism found itself in. So in principle, using things like, MinION sequencing, for example, where you can detect methylation patterns, as you detect these nucleotides, you should, in principle, be able to differentiate between, like, this came from mice, likely, versus this came from humans. And I know that people are looking into that. And the question is if you could potentially do this, as we're talking about Canada here, in biofilms versus from a patient. It's possible. I have not seen it applied in a meaningful way yet, though, that really allows us to saying, like, yes, while it might theoretically be possible, is it really possible in practice? And that I don't have a good understanding. I don't know, Valerie, if you know.
Yeah, I'll just add a couple notes to that, is that, so the assay that we're using is the sequence. We don't try to sequence the amplicon of that, but it is specific to Candida auris. And in our research, we found that detection of Candida auris in wastewater across the country there's very poor clinical data reporting, as you know, but it did make sense. Like it was more often detected in certain sewer sheds that we would expect it to be based on some of the epidemiology of the illness. So despite all the complexities that might be present, the data still made sense. And then, yeah, somebody should do that research. It's just that I think, you know, who's going to do it and where's the money going to come from? Because that would be a big effort, but worth doing for sure.
Thank you. All right, I'm being told that we're also over our break time. So if there are questions, please find the presenters during our break or be sure to ask those questions online. We'll make sure we get those to the presenters to get an answer back to you. But at this time, we are going to take a 15-minute break. You can go visit the cafe, you can visit the restroom, you can get some water, just take a breather, stand up. Talk amongst each other. And then also Anna's going to bring back that networking sign up so that you can please use the QR code. Let us know that if you are in person that you are going to attend the networking event so we can give our venue the correct number of folks that are going to be there. So big round of applause to our presenters today. Thank you so much. Like a project funded by Stanford. Yes.
Yes, well, we work with, yeah, I mean, we work with an ICD, which is they have sites across. Cape Town, probably.
You definitely can tell calling spectrum.
Okay, I have 3 more success stories for you. So if you come join us again, that'd be great. So since its launch in June 2022, the Hawaii Department of Health's wastewater surveillance program has grown from a COVID-19 monitoring tool into a flexible platform for detecting infectious diseases across the Hawaiian Islands. It now tracks key threats like influenza, RSV, and norovirus at both the community and facility levels, offering valuable insights for public health action. Weekly samples are collected from water resource recovery facilities and long-term care facilities. At the treatment plants, 24-hour composite samples are collected with autosamplers, while in long-term care settings where flow rates are lower, a mix of composite and passive samples are collected. And these sites are first assessed for viable sampling points and consent is obtained from residents' families. The samples are analyzed using digital PCR, and the team is also validating a respiratory viral panel and is exploring metagenomic sequencing to expand future capabilities. Hawaii's island geography creates logistical challenges, especially with inter-island transport. While most samples arrive overnight, occasional delays can lead to temperature excursions and sample loss, so the program has adapted its planning to address these disruptions. The program's impact is clear. At one long-term care facility, persistent SARS-CoV-2 signals in wastewater preceded a confirmed outbreak by 3 weeks, enabling early screening and isolation that likely prevented wider spread. In another case, H5N1 was detected at a treatment facility, triggering rapid coordination. The Department of Agriculture traced the virus to a backyard poultry flock, and a full response, including sequencing and epidemiologic investigation, was underway within 2 weeks. Looking ahead, the department is expanding the program to include new pathogen targets, automate lab workflows, build sequencing capacity, and launch a public dashboard to share real-time data. Sorry. Oregon's wastewater surveillance program, managed by Oregon State University in partnership with the Oregon Health Authority, has evolved into a multi-scale public health tool capable of monitoring infectious diseases from the building level to international events. The program tracks a broad range of pathogens, including SARS-CoV-2, influenza, including H5, RSV, norovirus, and cryptosporidium. In long-term care facilities, the team also screens for Candida auris and carbapenemase-producing organisms using both molecular and culture-based methods. During the 2022 World Athletics Championships in Eugene, the program monitored wastewater for respiratory and enteric viruses, as well as performing enhancing drugs, demonstrating its adaptability to high-profile, time-sensitive events. 24-hour composite samples are collected from treatment plants, while neighborhood and building level samples are drawn from manholes and lift stations. And the team has also piloted low-cost passive samplers to expand reach. Wastewater data have led to direct public health actions. Positive Candida auris signals have triggered immediate clinical testing in healthcare settings. On university campuses, wastewater detection of asymptomatic SARS-CoV-2 cases prompted dorm-wide testing. Statewide data inform hospital staffing, supply planning, and local outbreak response. A weekly county-specific newsletter is distributed to wastewater operators, health officials, and hospital staff, offering localized data interpretation, sharing success stories, and strengthening stakeholder engagement. Oregon's program, shows how wastewater surveillance can be integrated into routine public health infrastructure, offering a scalable, flexible, and actionable system for early detection and response to emerging threats. The Texas Wastewater Epidemiology and Surveillance Program, led by the Department of State Health Services, collects samples twice weekly from 21 sites, including 20 municipal treatment plants and at Dallas-Fort Worth International Airport. Sites are selected to reflect Texas's geographic and demographic diversity. The program monitors SARS-CoV-2, influenza A and B, RSV, norovirus, Mpox, and others using RT-qPCR and next-generation sequencing. During a recent measles outbreak, the team rapidly expanded sampling and developed new testing methods. Results are normalized by sewer-shed population and flow, with testing conducted at Baylor University and the State Public Health Lab. Weekly reports are shared with local health departments and facilities, summarizing findings, trends, and recommended actions. The reports include visualizations and appendices with methods and resources, along with the raw data. Local health departments apply these insights in real time. In Tarrant County, a norovirus spike detected in wastewater in September 2024 preceded a rise in clinical cases by about a week. The county also integrates wastewater trends into syndromic surveillance reports, leadership briefings, and monthly infection prevention meetings with long-term care and acute care facilities. Tarrant County plans to use current wastewater data to establish a baseline for monitoring pathogens during the 2026 FIFA World Cup. At Dallas-Fort Worth International Airport, surveillance data support internal public health readiness and coordination with local agencies. Pathogen trends inform operational decisions, such as enhanced cleaning protocols or targeted messaging, and contribute to global surveillance by flagging health risks related to international travel. The program has developed a response framework based on pathogen levels and hosts quarterly community of practice meetings to share lessons learned, supported by partners like the Houston News Center of Excellence and the Texas Epidemic Public Health Institute. I'd now like to introduce Rebecca Schneider, who is a staff analyst at the Houston Health Department, who will be moderating the next session.
Okay, how's this volume? Awesome, thanks. Yes, I am Rebecca Schneider, a staff analyst at the City of Houston Health Department in their data sciences and wastewater surveillance teams, and I'm moderating our panel on pandemic preparedness. For today's agenda, I'll go over a few ground rules that are the same as last session's, introduce our panelists, then we'll open up to a moderated Q&A, and then we'll open up to audience questions. And we'll end with a challenging question to our panelists. So for ground rules, again, just please hold questions until the audience portion. In-person folks line up behind the microphone, and online folks, WEF is moderating the chat and will speak for you. So our panelists today, I got to meet them all a little bit ahead of time, and we had a lot of great discussions then. So I'm sure this will be a great discussion today. We're joined online. Oh, great. We're joined online by Saskia, and she is an epidemiologist at RAND, a nonprofit, nonpartisan research organization working on the team that is advancing implementation of wastewater environmental surveillance. And prior to this role, she was at Netflix, building their global COVID and health response on the production side. Start a timer before I forget. Okay, great. And then here in person, we have Alex, who is the chief of the surveillance section at California Department of Public Health. He described to me beforehand that he did a lot during the pandemic, and they sort of like gave him, like, let's give him the wastewater surveillance program. And we're very, very glad they did. He did an environmental surveillance fellowship, and that involved sampling drinking water and river water for vaccine rollout. Then we've got Martin, who is a senior scientist with the University of Wisconsin-Madison State Laboratory of Hygiene. He serves as research lead of the Wisconsin Wastewater Surveillance Program. And outside of wastewater surveillance, his work has taken him to around the world, to the top of an ice pack in Greenland, to Kyrgyzstan, to Tibet and South Africa. So a lot of travel tips from Martin, probably. And then lastly, we've got Anthony, who is professor in microvirology and microbiology at Baylor College of Medicine in Houston, Texas. He is the PI of a statewide effort in Texas to track viruses in wastewater using sequencing, and also describes himself in his other work as a microbe hunter, and is an avid outdoorsman, which is very hard to keep up in Houston. I tip my hat to him. And this outdoorsman and microbe hunting did lead him to the middle of Galveston Bay on a kayak collecting samples.
Which flipped.
Which I wasn't going to add, but he did say which flipped and he was stranded. But please check out their full bios in the program. Okay. Before we get into the moderated Q&A, actually, I want to ask a question for everyone here. Please, by show of hand, who was involved in wastewater surveillance and research prior to the COVID-19 pandemic? Anthony, yeah, okay. And then, as you might guess, the next question is, who here is involved in wastewater surveillance and research because of the COVID-19 pandemic? Okay, this went how I thought it would. Exactly, a lot of us are involved in wastewater surveillance today because of the COVID-19 pandemic. In my experience as someone who works in the day-to-day of a local public health department's wastewater surveillance program, we've moved beyond COVID in our wastewater program, and maybe you've experienced this, we're like selling wastewaters, not just COVID, but we've learned a lot in COVID pandemic time for wastewater surveillance. And so let's today talk about what we learned then and wastewater surveillance in the next pandemic. Okay. So Martin, as you knew, you were the first question. To start us off, can you speak on the NATO Preparedness Summit that you attended in San Antonio and how wastewater surveillance fit into that conversation?
Sure, that's a big topic, and obviously pandemic preparedness is a huge topic, but NATO, ASTO, APHL, WEF, we're all trying to find a role for wastewater surveillance in the traditional public health practice. And the NATO meeting had multiple sessions on how that might fit, examples of how that might fit, challenges, lots of funding discussions. In fact, when it came to FEP funding, if push came to shove, the traditional surveillance would probably rule out over some of the wastewater just because of people resources that were not available. There were also lots of frameworks that were discussed. I mean, obviously there's, WHO has come up with some really nice frameworks. Anyway, they've come up with the pandemic preparedness, official agreement recently. Unfortunately, we're not necessarily party to that at the moment, but that hopefully will change. And the NASEM report has, identified some key roles for wastewater surveillance in traditional public health practice, and making that the traditional public health practitioners comfortable with how wastewater surveillance can be used is and making sure that that's kind of officially recognize limitations and challenges in an appropriate way. I think that's was a very important discussion. And finally, I think in terms of those frameworks, in terms of traditional practice, in terms of response and recovery and preparedness, many of the kind of the prescient things that news came up with early on in the back in 2020, when we had this multiple legged approach to can we monitor the kind of the trends over time? Can we use it to detect new pathogens? Can we use it to understand kind of the endemic or pathogens that we know might emerge and monitor their emergence? Some of those multiple legs of wastewater surveillance practice were kind of overlap and align with many of the traditional public health goals. So that was kind of the discussion.
Yeah. I liked when we talked about this before, how you mentioned how news had it in their three-pronged approach, that like pandemic being one of them, or disease X. Saskia, can you speak on your work in RAND in defining and measuring the value of wastewater surveillance for pandemic preparedness?
Yeah, thanks so much for having me. So RAND has been working in biosurveillance for a while, and I think wastewater is just one component of it. We've done a lot of exciting work in the past, more from the biodefense perspective. So really looking at environmental surveillance, that includes programs like BioWatch, BioSense as syndromic. And I think one of the really exciting things that some of my colleagues have done is looking at the importance of sustaining wastewater environmental surveillance programs and expanding them, what that looks like through the national program, but also what are the net benefits. So there was more recently a publication that found that there's, if you maintain these programs, you can have a net benefit of nearly $1,500 per person in the first year of a COVID-like pandemic. So they found that under those baseline assumptions, with a 5-day kind of early warning system, this relative to syndromic, if you think, it could actually reduce deaths from 149 to 134 per 100,000. And that monetary saving, I think, is really significant in especially this climate that we're finding ourselves in terms of trying to assess value. And so my work right now and a lot of the projects that we have on biosurveillance, but specifically wastewater surveillance, is really looking at valuability. How do we measure it? How do we discuss wastewater surveillance at the larger kind of post-pandemic, post-public health emergency perspective? And this right now involves forming a logic model where we're assessing about 152 different wastewater program evaluations and looking at how we can really look at outcomes and propose outcomes from the public health and larger national perspective. So things like lowering disease burden, of course, reducing the risk or likelihood of a high consequence disease event, and improving resilience for the public health and healthcare system. So I know I'm preaching to the choir about the value of these programs and systems, but really emphasizing and studying how we can make them as robust but also agile as possible, because increasingly our work is really trying to focus on how we maximize wastewater surveillance, but also avoid fragmentation and ensure coverage that doesn't amplify existing inequities.
Yes, RAND has been doing a lot of interesting work in this space, and there's a RAND paper titled "The Case for Sustaining Wastewater Surveillance Capabilities in the US," kind of speaking to what you said, that I recommend everyone here read. And one of my favorite statements from this paper was that sustaining wastewater surveillance capabilities will save time and money that would be required to rebuild the system from scratch during a future pandemic. So for my three folks here who are currently part of a wastewater surveillance program, how long did it take for you to build your wastewater surveillance program? And if you can, mention what funding sources you used to give us an idea of what would have to be rebuilt. And Alex, I'll start with you.
Thanks. So, which, yeah. Oh, okay. So in California, we started doing wastewater surveillance towards the end of 2020, and that was through seed funding from the CDC news program, ELC, similar to I think a lot of other state programs in the country, and how we got started. And really, that just gave us enough funding to be able to hire one epidemiologist, Angela, who's here with us. And from there, we really leaned heavily on a lot of different partnerships with the state water boards, with wastewater utilities, with laboratories, academic groups in the state. And this was a time, of course, when everybody was really interested and invested in trying to help. And over the first 6 months, first year or so, we really built this really strong partnership throughout the state. And that's really what allowed us to build our program. And then from there, we developed our in-state laboratory, and then expanded further to really have what we have now, which is a network of sites throughout the state, trying to provide data on a lot of different things. And there's really two different parts that have, or maybe three different parts of the program that have been really important, have taken years to build up, and we're still building. Those include laboratory capacity, of course, to do the actual testing. And then second being epidemiology capacity to really understand this new field. Really, when we started, we weren't sure that this was valuable, that this was going to be something that was, provide anything that was useful to public health, let alone be a sink of resources at a time when we really needed more. And so that's really taken time. And with every new pathogen, even for things like COVID, we're still building this work and trying to understand what is this data actually showing us and what gaps is it filling in public health. And the third is those partnerships and those collaborations, and those have evolved over time. That the players have changed, but those same relationships with people who were not familiar with working with in public health have been really instrumental. So environmental engineers, wastewater utilities, environmental health groups, et cetera, One Health, animal health, all these have been really critical. And as we move forward, I think all those are going to be important to continue if we want to be able to have the ability to do pandemic preparedness or anything like that. And those are not things that are built overnight, and would take us and continue to take us years to build.
And Martin?
Sure. Like Alex, we started early in probably April of 2020, and our origin story is a little bit different in that the planning and the initiation of the program started at the lab, and we had a strong academic connection. Our lab is part of the University of Wisconsin, and we have lots of wonderful partnerships with the academic community, and that allowed us to jumpstart the program with technical knowledge in hand, with a group of capable scientists, many of which are in the audience here. And then we also had an historic relationship with wastewater utilities, and that professional working relationship helped. So starting in we got some seed money from ELC, just like Alex, and by in June of 2020, by August, late August, we had up and running a program at 72 sites across the state of Wisconsin, and that was the basics of it. And a couple of months later, we brought on some capability at the state health department to build dashboards and kind of the beginning, the epi component of it. But so I think the lab has benefited from a lot of those academic collaborations. There was a great amount of just tremendous sharing across the whole community in helping everyone else bring up the program. And I think that was really, really, really valuable. And having that utility partnership, and more recently with kind of the industrial community, Promega's in town, and we can work with them on building on new methods. But I'll echo what Al said. I think we're still it took longer to build the epi capacity at the public health department, and we're still working on that. But I think that's making great strides, and so we're incrementally improving our methods and efficiencies, and kind of trying to figure out where how can we make the data that we collect as actionable as possible? So, sorry.
10 years. Since 2015, it's taken 10 years to get to this point for us. There's a poster over there if you want to have a history of it. In 2015, we're trying to look for pathogenic bacteria because they carry drug resistance, and we want to be able to follow those bacteria. But we also were looking for wastewater for medicines. You could actually find medicines in wastewater, and we develop therapeutics and treat patients with the medicines from wastewater. This is like about this conference has been about the negative elements, but we like to look at wastewater for that. SARS-CoV-2 was April 12th, 2020. We already had wastewater samples, and we thought this virus is going to be in wastewater because it infects intestinal tissue. And so we did PCR, and that led to a cascade of sort of getting into the viral part of it. And then in 2021, switching to every virus everywhere all at once. So basically the program now is we're looking for all viruses in a single sample using sequencing-based methods. That started to kick in really well in early 2022, and that's what we're currently improving upon now.
And that's a program through the Texas Ledge versus like Houston's program versus Texas DSHS program. It's sort of a lot of relationships that were wastewater surveillance to go away. I think we all in our programs building up those relationships again, and it's okay to keep it all these programs now, but spinning it back up would take a while. So looking forward, and this next question is for each of you. What is one area that the wastewater surveillance community needs to address to improve our programs? And Saskia, I'll start with you.
It's tough. I think, I worked on the frontline response in healthcare for the first year of the pandemic, and then I went and worked with a global company that was looking domestically and abroad. So I think there's kind of a two-prong facet to me that needs addressing. The first is communication. And, a good friend of mine always says that science isn't complete until it's communicated. And I think we really learned a lot of lessons about how we translate the information we find into action, which leads me to the second part, which is really, and that also means trust as well, but decision making. One of the hardest things is taking that information and conveying it, but turning it into what does this mean and what do I need to do now? Is this kind of sit and wait? Is it we need to couple it with additional findings? Do we need to ask more questions, implement additional measures, et cetera? So I think that's probably the hardest part. Some of the work I've been doing at RAND, but just speaking from, kind of that frontline response, but then also when you're conveying it to people who don't work in public health or even policy, but a totally different private industry. And they're saying, well, what do I do with this information? And where is our metric for hitting the oh panic button? Or, maybe we can wait a little bit. So I think those metrics, those thresholds are increasingly important, especially when it comes to larger policy-making decisions about the value of these programs.
And I'll go backwards. Anthony.
Yes. I think the interaction with the community for us, as an academic scientist, my head's always kind of buried in the bench. And I was talking about HIV detection a couple of years ago because we monitor that too. And it was the audience was largely community people, and someone raised their hand and asked me a question that I'll never forget, and has just changed my perspective since then, which is, if you report HIV on your dashboard, are my property values going to decrease? And what it really spoke to me about was that, we really do have to think about the ramifications of what we're detecting and how we report it. And so when Rebecca asked me the question, I listed communication first as critical, being accessible. Ali mentioned earlier, not a day goes by that I don't get an email asking, you're detecting adenovirus 34 at site, 12. What is that? There's not even a CDC link on what that virus does, right? And then finally learning how to follow the rules. So we have a reporting procedure. When we first detected SARS-CoV-2, I was sharing the information rather naively with the president of my college. He actually gives a weekly report that's on YouTube. A newspaper outlet picked up the report, and it was in the papers that an outbreak was coming before I even made the graph. And what that taught me was that this information really, it has a way to affect communities and put pressure on public health folks in ways that you, as a lab person, can't really understand, and that's critical.
Martin.
Sure. I'm not going to argue with any of the comments that are expressed by Saskia and our partner to here. It's certainly trust, communication, messaging is super important. I know that there'll be discussions later tomorrow about what I would think would probably be one of the single most important considerations is actionable data. How can we improve the data such that we can make more informed decisions? And I think that's key, but I'm going to leave that to discussions the second day. So I'm going to then fall back on some of the things that previously been discussed, and that is, for the modelers of the world and for when we move this beyond some of the pathogens that we're currently working on is, understanding shedding rates, understanding, degradation in the sewer systems, and importantly, understanding kind of the zoonotic One Health kind of approach. All these, throwing out dozens of different things that we need to do instead of a single one, but I think those key data gaps are fundamentally going to limit some of the broader approaches in the future.
Alex.
I would echo the communication points. I think just add something different, I guess. I think that not taking for granted the basic work that we've done, and we're kind of entering this new phase of wastewater surveillance where I think people know what it is. Nobody's presented this is how wastewater works yet. And in some ways, I think people sort of assume that wastewater is going to work for this new pathogen that will look like an epi curve and it'll just be like COVID or something else like that. And even at the heart of it, we don't understand how it works for COVID, right? There's so many other things, variabilities, what is high, medium, or low in COVID, right? These are still unanswered questions that are quite critical for public health leaders, epidemiologists, people who look at this data all the time to understand. And I think continuing to focus on really basic questions that at this point maybe seem not as exciting, but are still just really fundamentally important for this new field and making wastewater not something that we just fit into the paradigm of everything else we've done in public health, but really establishing it as a new field and trying to understand what its role is, what gaps it fills, and how we read it and communicate it. I think really continuing to think about those basic things.
I'll go back to what you were saying, Martin, about shedding rate and illness that the wastewater represents, or even what human illness the wastewater represents. The wastewater community thinks a lot about wastewater and cases and metrics. And so this question is for each of you about how we keep that conversation about the relationship between wastewater and the other public health surveillance metrics. How do we address that relationship as we lead into the next pandemic, or as we prepare for the next pandemic? And Saskia, I'll start again with you.
Yeah, I think I'm going to probably say it 1,000 times, the threshold for action. When I was in healthcare and we were looking at wastewater surveillance, it was kind of like, well, how do we integrate this with the clinical information? And one of the things that I really wish we had is, instead of the siloing of different surveillance networks, how can I use this within healthcare paired with my clinical cases, paired with my syndromic surveillance? And knowing that risk reduction is additive, all of these things are going to help. So I would love to see that, because there is a lot of siloing, but I really don't think we train a lot of the clinical EPIs in healthcare to really use wastewater surveillance for that decision making, but also the capacity to translate it and what that means for healthcare leadership and how we integrate it with other data points. No single data system, no surveillance system is perfect. So what are the pros or the cons, and how do we interpret this data in really that frontline capacity? And it's going to be entirely different than that within the private industry. You know, how I communicate to a business continuity or intel specialist is their question is this going to cost me money? Are we going to have to shut down something? Very, very different. You know, their risk assessment and their risk thresholds and perception are very personal. So when I look at the hospital components and their integration with clinical is very different than, you know, when I was at Netflix and the question was, well, does this mean we're going to have to put the movie on hold? And that seems silly to a lot of us in the room because it sounds, you know, a bit ridiculous, but the truth is that that's 1,000 people working, millions of dollars. And every time we send people home, that means they're likely exposed and, you know, back in the community, and we're not testing. So there's different thresholds for how we integrate that data and what it means to each stakeholder.
And Martin.
Sure. I think we also have to keep in mind that we need to, you know, consider that, you know, that the data gathering should be kind of fit for purpose, and that, you know, we emphasize the, you know, the case correlation, rightly so, I think, with SARS and now with influenza and some other viruses, and that, you know, that was an important tool to help, or important study to document that, you know, this does work in terms of, you know, convincing yourself as well as, you know, the kind of the public health practitioners that this is a viable alternative. But, you know, but that's viable for maybe two of the wings of what we might consider wastewater surveillance summit. But, you know, the, you know, detection of emerging, you know, new pathogens, or pathogens that, you know, like Mpox or N5 or H5 that are sitting dormant, that might reappear. I mean, that type of threshold of action and actually the design of the network is going to be quite different. And I think that, you know, the focus on cases in that case is misleading. So I think that's, you know, you're not going to have the cases really. You need to think about that in a different way, and what level of action would incur from a, you know, a detection rather than a trend. So.
And Alex.
Sure, just to add to that, I mean, I think it's important for us to continue to look at cases and how they correlate with wastewater, and that's not always possible. COVID was probably the best surveilled disease ever, and so having that kind of data to compare to wastewater is great. But that wastewater, I mean, I think we're continuing to see new uses for it, and while it's good to try to build confidence and understanding through things like case correlations, it's not always the most important, because, like as Martin said, the use cases may differ. In H5, we really found that it wasn't valuable or important for necessarily human cases, right? But we found that it was correlating really closely with dairy that was infected from infected herds that was probably being dumped down sinks. And then that actually correlated with our state herd infections and really gave us an important new kind of indicator that really wasn't about cases at all. It was really about sort of our statewide response and statewide situation around H5, and that itself was helpful, but a totally different use. And similarly with Mpox or things like that, you know, of course, we all want to know how many cases does this one detection mean, and what does this all tell us? But at the end of the day, some of the more useful information might be, are we continuing to see this? Are we seeing this growing? Things like that are more about transmission or something else beyond just cases. And so I think it's a good and important part of the equation, but certainly not all of wastewater.
Anthony.
Yeah, I'll just keep it brief because everyone said such great things already. For me personally, I think that it's the most challenging question for public health in this area. And I don't think it's going to be answered easily, but I would advocate for very situationally specific. And by situation, I almost mean pathogen specific risks. You know, each one of these pathogens has a different mode of transmission. Each one presents with different clinical impact. Each one has different outbreak potential. And we've already mentioned zoonotics. So I almost think it needs to be one glove fitting all is probably not the approach. I think it's very pathogen specific. And then I think we got to define which pathogens are the ones we need to talk about first. And then the last part is, Alex mentioned about clinical data and how well it validates. We found that to be exceptionally helpful. If we could get our hands on more clinical data, we get more people to be believers in what we're doing. So the one way we're trying to tackle this is to now mine the health records for the state where against all the IC codes. So, you're not going to have viral levels for some things, but you might have fevers, respiratory illness, or, IC code, whatever diagnosis.
And sometimes it's the people like you're not at a public health department getting access to the cases. And, being the health department you might ask in Houston, I might not willingly be throwing case information around, but creating that relationship. I mean, my first role at the Houston Health Department was calling labs and being like, you have to report COVID results. Like, you aren't reporting them to us. And getting that ready for the next pandemic. And I'll keep us kind of on time. So we're talking, we've obviously gone off from just COVID, and pathogen prioritization is a huge thing that this community talks about. And we ask ourselves what to prioritize, and people ask us what we need to, what we should prioritize. And once the targets are on a list and it's like, okay, this one's number one that we're going to prioritize. And Ali gave a great talk about how they prioritize things. There's a lot of work on the lab side that has to happen to actually make these things detectable in wastewater, or to find if we can. So for my lab folks, Martin and Anthony, how ready are we on the lab side to detect the next pandemic and pathogen in wastewater? And what platforms or approaches should the lab community be developing? And I'm going to start with you, Martin.
And I am going to toss, I'm not going to toss it, but I'm going to just leave my comments about whether it be agnostic sequencing or targeted sequencing or large panel sequencing of a large array of pathogens. I'll leave that to Anthony, and you can cover that, but I think that's clearly an important component of where we need to move forward. I mean, we find those gaps. I mean, immediately. I mean, we identified a Hep A outbreak in one of our large event monitoring, and we didn't have the sequencing capability to really act on it. So I mean, we need that capability. So, but I think the the sequencing platforms, the PCR platforms, kind of the tools are, I think, pretty fit for purpose, and I think those are where I think we can. I think we do need better pre-analytical tools to help us improve the signal to noise of many of these measurements that we're making, and that will ultimately lead to improved data actionability. And so that means, whether that be more efficient and more selective capture concentration approaches, whether that means tools to clean up the samples to make them more amenable to both sequencing and quantitation. I think those are key areas. An area that I think we have neglected to some extent is on, as it certainly applies to the sequencing side, is the bioinformatics side of things, just the human resources that we need to implement some of these sequencing platforms that we're going to be increasingly using in the future. So just a few topics but there's okay, sorry.
Yeah.
Sequencing. It's like what I say in realty: location, location, locate. Sequencing guys says sequencing. So PCR is the workhorse, and it's also very cost effective, and technically it's reliable and user friendly. PCR needs to be for high importance viruses or pathogens, needs to be the workhorse. But I think for what's coming, sequencing allows you to render visible what is really well below not only the technology of PCR, but also the clinical radar. And I think Christian talked about it, he kind of hinted at it very importantly. You have to remember that these microorganisms, their fundamental threat against us is their ability to rapidly change. That's what they do best. They evolve quickly. Most of them evolve very quickly. And those genetic signatures or changes are it is the fingerprint left at the scene of the crime for what's coming. And so tools that can sort of bring that fingerprint to the forefront and then make it visible for everyone else is really what we need, because the sequencing nerds like myself can look at something one way, but how do you translate that to somebody sitting at home on their smartphone wanting to know where avian flu might be jumping to humans, right? It's a different challenge. So I think for early detection and pandemic preparedness, I really like the approach of genomic, we can't say surveillance in the state of Texas, genomic monitoring. So.
Okay, two more questions and then we'll open it up to the audience. Martin, can you speak to some simulations or exercises that can be performed to ensure that we're truly ready to hit the ground running for the next pandemic?
I can try. I don't know. I will frame that in terms of my primary laboratory perspective, but we run a network-wide proficiency testing program, and we also we're co-located with both our clinical division and our laboratory response division, and I think we can learn a lot from the LRN as well as build into our proficiency program essentially a way that we can challenge the labs that are participating in the network, challenging the jurisdictions in the network with either unknowns or knowns. These are 50 samples. You turn them around in 2 days and you tell us what the concentrations are, or tell us what the lineages are. That is that's what CDC expects of the LRN. Why shouldn't the CDC expect that from news? So that's something that and extending that to some of our other center of excellence focuses that our COE is working on is large event surveillance, and using that as a tool to exercise the larger public health component, in that you bring in your state EPIs, you bring in the local health, you bring in the whole suite of partners and stakeholders into that, and challenge them with, these are the plans that we developed for this pathogen. These are the pathogen action plans that, we see this is what we do. If it goes over this threshold, this is what we do. So you can use the large event as part of that, or you can do kind of a desktop like maybe the FEFOs would do. But I think there are quite a few things that we could do in that general area that would kind of document and demonstrate to the communities that we're able to deal with something new.
And I think we're getting set up for, I'm going to speak this into existence, having a large event monitoring network of experience for when the World Cup comes next year. Everyone is thinking about it, and we're all thinking, like, just internally at the health department, the emergency person emailed our group to be like, hey, what do you monitor for in wastewater? And it's like, these discussions are happening at each little location. We need to bring everyone together. And bringing everyone together on an even wider scale. Pandemic implies not just happening in the United States. Saskia, your role in Netflix brought you to working with a lot of different countries. Can you speak to what you think global wastewater surveillance system means and how we get there?
I think that's a tough question. I mean, we're already seeing a lot of really amazing work with the pandemic treaty in terms of data transparency and sharing. That's the first part. But we really struggle to have a global dashboard. And I think that's going to really come down to access to technologies and equity. So I think we're going to have to get ahead of that. There's been a lot of collaboration with private industry. Like Ginkgo has set some things up, but collectively there's a lot of fragmentation. So I think from the global perspective, we're going to have to decide to actively invest in this. And it can't just come from the Gates Foundation. It really does have to come from every single country investing in this. And I think right now in the United States, it's quite challenging because, we have these amazing systems in place that could contribute to that. But because of funding stresses, we don't really know what that's going to look like. And I always go back to this notion that, we like to rely on the phrasing, disease knows no borders, and that's technically true, but some countries are inherently more robust and resilient and ready and can contribute information and sharing to that. So I think there's going to have to be a lot of emphasis on that active engagement and not just that passive engagement. And I will say there's one thing I really found with Netflix, which was really interesting, is that we got them to understand the importance of wastewater surveillance, like a lot of private industries that were responding to COVID-19. But believe it or not, and I think there were some publications with the NFL or NBA where they were sharing their data, but so many of these larger industries that are extremely well funded haven't shared their information. There's not necessarily incentives to that. And they're still maintaining that surveillance. I mean, Netflix isn't anymore because of COVID, but we were on a global scale testing people PCR 3 times a week. And you're talking about hundreds of productions globally. And that we had gender, vaccine status, repeat infections, et cetera. That is a wealth of information that just kind of went nowhere. And when I say a global dashboard, it's not just at the country level or the region level, but we also really need to get in some of those private industries that are investing in it, or get them to see how it's also a part of business intelligence. And I think that could build a really, really amazing network that would be highly effective.
Oh, wow, great. Okay, so we are wildly behind time. We started 20-ish minutes late, and I had allotted 20 minutes for audience time, but maybe we can cut that in half and do 10 minutes of audience time and open it up to the audience. Okay, thanks. And please, a round of applause for our panelists. So when you come up and ask your question, state your name, your organization, your question first, and then any context for the question.
Can you guys hear me? Yep. So my name is Anil Mangla. I'm the director for disease surveillance and control for the South Nevada Health District, which is Las Vegas, and faculty at the University of Nevada, Las Vegas. So again, being in a health department and academia, research is great, preparedness is great. I call this a additional tool in our toolbox for epidemiology. It's worked well in Vegas. It's been proactive because we have a lot of mass gatherings. So the question I have is more for our Texas folks, right? Now we've come to a point of ethics. And so Texas is now monitoring mifepristone and estrogen. Where's the ethics with that? Where's the privacy, and where is that going? And then to your question, you've been monitoring medications for the past 10 years, right? So have we now come to a point where using this as a productive epidemiologic tool is going to go away because it's going more towards, the ethical part of monitoring abortion medications and so forth?
Looking at each other like you should.
Anthony, no questions.
All right. Well, this is a tricky one. First, one clarification. We don't monitor medicinals in wastewater. We search wastewater for new medicines and we develop them as therapeutics. Bacteria make antibiotics. You can make new drugs with them. So that's what I meant by that. I'm aware of this proposal or legislation or whatever. And I guess what I'll say is, as part of our program, we have an ethics working group. I talk a little about it over there, and it's kind of their job to address these issues. And so they are actually trying to build a framework around what is, too intrusive and what isn't. And the hope is that they'll release that in an academic setting, and that'll be a guide for a lot of these questions. But there's no doubt that wastewater can be used wastewater information can be used nefariously. You may have noticed I've avoided talking about the human genome, but I'm certain that I could assemble a human genome from wastewater and match it to people. We get rid of that data. It's, you know, we caught red-handed, but so these are great questions.
Hi, I'm Prakit Singh. I'm from Hawaii State Department of Health. We, as one of the slides showing that we are also collecting samples from the long-term care facilities, and our lab director really have the vision that the wastewater testing at the care facility is going to be really important to help prevent like the outbreak and the impact. But one problem that I think we are encountering right now is when we talk with the care facilities, so there is wastewater testing team, and then the epidemiologist team, also the care facility team. The care facility team, they many times they feel hesitant to get on board with us because of the many more tasks that they have to do following the detection of targets in the wastewater. And I think this is the main reason that they probably don't want to participate in the testing program. So I want to ask your suggestions, or maybe if you have experience on this, how can we make how can we prepare and make the program also more friendly to the team, like care facility team as well. Yeah.
Maybe I'll just briefly start. We're kind of addressing some of those same issues with the program that we're initiating, and you know we've talked through many of those questions, and we don't necessarily know how it's going to turn out, but saying right up front that detection does not mean I don't know what your state means in terms of if you see something that implications for regulatory action, but if we see something that it is not intended in terms for a regulatory point prevalence survey or something like that, we are ultimately here to try to understand whether this tool at facility level monitoring will actually reduce your burden over time in terms of the need for monitoring and point prevalence work. So being very upfront about that you're helping us understand this use case, and that there should be no negative repercussions in terms of helping us do that. And ultimately, we hope to. Anna's shutting me down. Sorry.
No, that was to me that she has a question after this, but yeah, you're fine.
I'll add really quickly to that. I think it's important to remember that care facilities incentives and goals may not be the same as ours in public health. Like Martin said, that is our purpose right now, is to understand how this might be useful, and that's not exactly super motivating for a care facility who's worried that we're going to use this data and come and say you have mysterious CORIS that we have to shut down, blah, 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 or you have to do more testing now, right? That's not aligned. So I think for us, we do have to figure out where is the value add and how does that help long-term care facilities? Does it decrease their screening? Does it prevent outbreaks? Things like that. And obviously it's difficult when we can't do the work to start with, but it is important to keep in mind what is the actual goal and how does it add value to these places.
Thank you.
I'm now going to go to Anna with her online question.
Yeah, we don't have any questions yet online, but we have a comment. And this relates to Anil's question. And the comment is, I think that it's part of all of our jobs to be aware of the ethical implications of the work. So back over to you.
Thank you for that comment. All right, thank you.
All right, I'm Ishi Keenum. I'm from Michigan Tech University. I think my question is really targeted at the sequencing approach, or what is it, the diagnostic kind of idea. And while I really love that that would be kind of our way to detect new pandemics. I worry about things like detection limit or how prevalent does something need to be before we can actually see it.
For me, yeah. Real quick, on the ethics front, there's a poster here by Jennifer that's part of our group that answers some of these questions. She can help you along there. The way I view this is rather simplistically, and it is kind of a cop-out, and it's probably not fair to the public health folks. When we talk about this in the lab and we see something novel, we report it, right? We give all the evidence. So measles, for example, Arapooch virus, avian flu, these are all monkeypox. Before they were in the news, we were seeing them in the data. We have an SOP about how we report. Thresholds for whether to take action. I honestly believe that right now with the sequencing capabilities that we're using, it's so far from the standard practice that it's going to take, I think, a long time to work out. So we recognize that's a limitation. But we like to think about it as a weather report. In other words, a storm is coming. We don't know if the tornado is going to destroy your house, but it's coming. And we just want you to be aware of it, right? So it's kind of a cop-out, but.
The kind of cop-out that we kind of put into some of our MOUs is that, this information should be filtered through, your public health EPIs, and that, they should have a decision-making authority on whether that data should be, and at what level that data should be released. And so, monitoring, the broad range monitoring is fine, but I think we need to make sure that, public health understands the actionability of that data.
And Anthony, the SOP you're discussing that TEPV has, that's available, right?
Yes.
Yes, I was about to say, like, you could ask them and they'd be happy to
And
share.
Jennifer is in this room. She was leading effort to develop it, so she could fill you in on how we got, it was an evolution, but.
I'll add quickly to that. I mean, I think all of these approaches we're talking about, sequencing, I think plays a really important and valuable role. I think all the works, proteomics, all these things could play a role in the next pandemic, right? Or emergency response or something along those lines. And I think the more we use these examples or experiences, right, the next pandemic or next emergency use might not be something we predict, right? Probably won't be, or at least not clear. But our experience with CORS, even if it's not necessarily useful for what we think it is now, gives us experience with fungi, right? And things like that. And I think all these experiences on the epi side, lab side, all of it will be helpful. And if we continue to push those use cases and understand the limitations, all that will help us be more prepared for the future.
Hi, I'm Allie Bing from Stanford. Should I go ahead?
No, you're
Okay. Yeah, so this is really a follow-on question, and it's for Alex and Tony, and it's about the viral metagenomics. So Wastewater Scan is hoping to trial this idea of scaling and using metagenomics across the country. And we don't know yet if it'll work or how you guys will if you will like it, or if the data will ever be public or actionable or anything. But I mean, the technology's there, but the tricky part is in the translation of that. And so my question I hope I didn't scare anybody, because we're not going to this is the beginning of a research project, not something that's going to appear on the dashboard anytime soon or anything like that. And you will all be informed completely of everything we're doing. But this is just an idea. But I was curious, I noticed on your dashboard, Tony, that you only show a handful of pre-picked pathogens that come from your genomics, but you mentioned other ones that aren't up there. Yes. And so say that you detect Ebola, how do you have one read? How do you think about sharing that kind of information? And then Alex, as a public health rep up there, how do you feel about the public getting hold of that kind of information, or what kind of masking of the viral metagenomics data that you're showing do you think about? Because you obviously are masking some of that data that you release to the public. but you're not masking what you give to public health? And how do you think about information sharing? And Alex, like, what do you think about that kind of, I mean, these are really hard questions, sorry, but something that I've been thinking about, so.
Maybe I go first and then you tell me if I did a good job. So we try to speak three languages, Ally. The first is the language of the community. And so we convert genomics information into up and down arrows or color coded, warnings. The second is for the public health folks, and that's a little bit more sophisticated, like trend lines, because everybody's used to seeing that. So we convert sequencing data into like trend lines. And then the third is for the genomics aficionado. So people like myself that want to take a deep dive. But we have two layers of communication, right? A curated layer, which goes public, and then a report that has much more viral species reported that go to the public health partners. And that decision came out of our action group. We have a community of public health folks, some community people are on there, physicians, and they basically recommended that if we put everything out there on the board, it would cause chaos because there's no context for, why B virus 42 is going up over here and something else is going right. So it's broken out by what people are accustomed to, really, mostly the seasonal. And then the public health folks get sort of a specialized report that has more of these concerning signals before it's released to the public.
Yeah, I think metagenomics is tricky, right? I think even when we have sterile clinical samples, what you see in metagenomics may not make sense, right? It might not be real or might not be causing what you're seeing in front of you. And when I think about it for wastewater, obviously the potential for that is even broader. And how do you interpret that and use that? The Ebola case is a good one. But I mean, I think what Anthony's saying, I think is right in some ways. I think knowing what our limitations as we explore that, what are the ones we feel confident in and we can share with the public or otherwise, or with public health stakeholders versus say the people who are really aficionados. I think that's important. And also being transparent. I mean, I think even if in the best case scenario, there's always a chance that the data will be misinterpreted, and being clear about what it is. I mean, obviously Ebola, even if you know for sure it's in wastewater, can scare the public, right? And that's added when you're not so sure what that metagenomic read means, right? But being clear about that and addressing it, I think, rather than say just purely masking or otherwise, I think is has to be part of the strategy as we kind of try to understand what these technologies can do.
And we do, Ally, we do make that clear on it's stated that this is a curated list, right? So, and we have a structure around data acquisition that people can ask for it and we can share. And if we want to take a closer look, yeah.
Anna.
Yeah, so I think there was a question online about anybody using metagenomics to find that potential pandemic potential pathogen. And we've heard a little bit about metagenomics. I didn't know if anybody else wanted to weigh in, Saskia or Martin, on that topic.
I just wanted to comment that I think it's really important that as Anthony said, that this, the steps that one needs to follow are documented critically in an SOP, but even more importantly, maybe in memorandums of understanding and data use agreements that that is information, who can use it, where the samples archived, the whole range of things, just to be really transparent about what can or cannot be used with these data and who can get their hands on it.
Yeah, I can add a couple of pieces. I think there's been an increasing interest in metagenomics, but really focusing on calling it the pathogen agnostic. And we're seeing that really post-COVID, but it's always been prevalent in biodefense, biopreparedness, but increasingly, we are seeing joint programs looking at medical waste streams in particular, CDC relationships with LabCorp, but increasingly through the Traveler Genomic Sequence Program, of course, but wastewater. And I think more and more there's a desire for pathogen agnostic because that feels like we're more likely to catch that pathogen of pandemic potential. And you will see, I'm finding at least a lot more of it from a securitization lens. So it's not just that this is a naturally occurring pandemic, but of course there's a lot of focus on nefarious actors and genetically engineered pathogens, which has always been a concern, but increasingly that is the lens of which we're seeing this. So I think, to me, pathogen agnostic is, you see it across the spectrum of biological threats, and there's so much focus on it. But I always ask at the end of the day, what is our response plan in place? So if you're going to look for it, you better have something in the wings ready to go, because that's always the issue. We ask the question, but we don't have the infrastructure in place. And that's not just the plan, it's the people, it's the resources outside of that panic neglect cycle.
Okay, last question.
Hello, my name is Laura Langen. I am at the University of South Carolina in Columbia, but I also work with Baylor University in Texas. And so I'm taking a step back here because we're talking about pandemic preparedness. We've talked about focusing on sequencing, metagenomics, the whole 9 yards. All of this is underpinned by workforce. Have we any thoughts, or has there been any plans for how we are going to make sure that the workforce is developed within that wastewater and epi context? Because, wastewater and the public health have very different sequencing acceptance criteria that is very different from clinical. And so, it's not necessarily an apples and apples comparison. How are you thinking about preparing your workforce? Because obviously you're an academic lab, so we have PhD students coming through, but obviously there has been a big shift in student applications in the last while, and that's probably going to percolate through for the next couple of years. So how have you started thinking about how we are going to do this, and broadly to the community as well, thinking about this? Because there's having all this focus on methodology development ignores the fact that we can develop all of these methods, but if we don't have people capable of actually implementing them, how useful are they?
So we've been working on, inherent in your question, I think, is education and scale. So we've been working on making this scalable for a few years now. The technology, so the best we can do is 3-day turnaround, right? Given the current state of the technologies, we can maybe, with a good source of funding, we believe we can modularize this in every laboratory around the world. And the computational tools are already publicly available. We design the scripts, we release them. All you have to do is take the data, put it in, and out shoots all the viruses, right? And tells you their levels. But the next generation of this is about creating an educational framework and training people, particularly within our graduate school, to take modules around wastewater science. And then also modules on how the public health can interface with the genomics of wastewater science to understand it and make interpretations. So we do have grants in the works that there's planning around creating educational modules that are both a student can sit on, but that we will create videos that people can watch online and learn from too. So public information from like a virtual format.
And just to follow up on that, APHL, CSC, WEF, even CDC, they have a fellows program. I mean, there's mentorship going on right now, both at the lab level and at the epi level. And so I think, it's kind of the immediate, information knowledge transfer is happening there. Obviously, that needs to be continued. That support needs to be continued and grown over time. But that's certainly happening right now. And WEF is developing coursework. As well as other organizations are developing, fundamental coursework in the area.
I think wastewater is cool and it's fun, and it's been picked up, favorably by the media. I think students seem to really like it and find it appealing, and have been asked to talk at undergrad, graduate school courses and things like that. And I think the more we can make it fun and less technical per se, I think just to get people into it, I think is helpful, but also develop the kind of technical expertise that's necessary, which I know a lot of people in this room work on exactly those things and trying to get postdocs and others to be involved in the work. And I think that kind of percolates down. But I think the field is just as a whole, I mean, 10 years ago, if we said we were doing something environmental surveillance to anybody, nobody would have any idea what that meant, right? Now you have students who are like, of course I know what that is, and random people on the street who know what wastewater monitoring is, right? And so I think it speaks to some of this. And I think a lot of the efforts, I know CDC News is really focused on trying to get educational tools, things out there to make this more accessible to people who are interested in it. And as the COEs, including our group in California, has really tried to focus on developing tools. That's part of our objectives, is to make this usable for places that, whether they're public health labs that don't have the resources or don't have the experience with it, or others to be able to access this and be able to kind of get into the field, I guess. But there's a lot of work to do, obviously.
Saskia, do you have anything to add?
I mean, I kind of come at it from the trying to get people to invest in it. I think when we can get people to see the value of it, and that was a lot of the work that I did, within Netflix, but also now from the policy side, is really having policymakers and larger organizations see the value of wastewater surveillance, which I'm hoping means there will be continued or increasing investment in it so that we can bring on more people and do more educational programs.
Netflix documentary.
Netflix. Alex says Netflix documentary.
And there's also a commercial connection here in terms of investment that I think we've shown that, once industry catches on, that there can be an investment that leads to technological innovation. And so it's a two-way street. And I think, we've had folks from AGA come in and say, well, what should we be doing? What can we help you to build? So I think that's, another aspect of it that can help with the training.
Well, it's an excellent final question because it really goes along with my challenging question that I'll end on, which is essentially, what is one thing people can do today for pandemic preparedness? We think of pandemic preparedness as something in the future, something a future person has to do. And research shows that we think of our future selves as a stranger, like that's someone else's work. So what is one thing, if you want to add anything, that was essentially a great thing, is educate our workforce. But what is one thing you might want to add about what people can do today for pandemic preparedness?
I think we need to be somewhat better advocates the best we can. So I think, being out there with success stories, being out there with, examples of where, this has proven to be valuable, a complement, if not primary mode of surveillance, and, be upfront with the limitations and build that grassroots kind of public support for it.
Anthony?
Register to vote.
And exercise that right.
I think not taking for granted that we still have a lot of work to do, and focusing on a lot of things that we've been already doing, and communication. I think I'm constantly reminded, or often forget, I guess, that we're really down the rabbit hole, people in this room, and we understand this stuff, but most people, even public health people, scientists, others, don't understand it and the complexities of it. And when we're kind of not clear about the way we communicate results, I think that can lead to setbacks to wastewater as a field, to the way this is used, to the perceived usefulness of it, all these things, the support for it, the need to support the continued development of these technologies. People, I think, kind of assume that we've already figured it all out, and I don't think we're there yet.
And Saskia?
I agree with everything already said. I would say, think about agility, because that's always the question that people ask, from the policy and the investment side, is this just, we can only do one thing with it, or how can this be applicable across the spectrum of potential risks, and knowing your audience. So, yeah.
Well, thank you all today for coming today. And I think, let me see, lunch is next. Oh, you can't see these slides. Thank you again to our panelists.
Thank you, everyone. everybody. That was a great session. Yes, we're at lunch. So there's this QR code gives you lunch options. The poster session will start at 1 for online folks. We will be coordinating with all the poster presenters to see if we can upload PDFs of their posters after the event, but you all are free from 1 to 2 Pacific online.
Hi, thanks everyone for joining us back again this afternoon. So we have our last 3 success stories of the day. So the first one is Arizona. Arizona's wastewater surveillance program is a growing statewide initiative led by the Department of Health Services with testing conducted by the State Public Health Laboratory. Samples are collected twice weekly from multiple counties, covering roughly 52% of the state's population. Most are 24-hour composite samples collected from wastewater treatment plants, with some taken upstream to capture more localized signals. The program currently monitors respiratory pathogens, including SARS-CoV-2, influenza, and RSV. Additional targets, such as mpox and arboviruses, are in the validation phase. A recent example of the program's impact came in November 2024 during Arizona's first major H5N1 outbreak. While the initial report came from a poultry farm in Pinal County, wastewater detections followed in Coconino County, Tempe, and Phoenix. These early signals triggered a coordinated response involving state and county health departments, laboratory partners, and wastewater utilities. The Translational Genomics Research Institute supported the response by testing for animal DNA in positive samples, finding wild bird and chicken DNA, which supported the hypothesis of avian contributions to the viral signal. In response, Coconino and Maricopa counties issued public alerts to raise awareness. With continued expansion and cross-sector collaboration, the program is positioned to become a vital part of the state's public health infrastructure. And we heard a little bit about this program earlier today, but learn a little bit more right now. So the Texas Wastewater and Environmental Biomonitoring Program, or TexWeb, is a statewide initiative led by Baylor College of Medicine and UT Health Houston School of Public Health, in partnership with the Texas Epidemic Public Health Institute. TexWeb collects weekly wastewater samples from 40 sites across 15 cities, with new locations added regularly to broaden coverage across diverse Texas communities. Using a sequencing-based approach, TexWeb monitors over 3,150 viruses and 15,000 viral strains without relying on predefined targets. This allows for comprehensive detection of pathogens in a single reaction. Key viruses tracked include SARS-CoV-2, influenza, RSV, norovirus, measles, mpox, and vector-borne viruses like West Nile, dengue, and chikungunya. The program is also expanding to include antimicrobial resistant bacteria, including drug-resistant tuberculosis. TexWeb provides actionable data in real time. In 2024, H5N1 RNA was detected in wastewater across 10 cities, prompting alerts and preparedness efforts, and sequencing of positive samples identified multiple animal sources. Other examples include norovirus spikes that triggered school hygiene campaigns, flu and COVID-19 signals that informed hospital staffing, and hepatitis surges in border cities that led to public advisories. By integrating environmental data into public health systems, TexWeb provides a scalable, cost-effective model for early detection and rapid response to emerging threats across Texas and beyond. In Cordoba, Argentina, wastewater surveillance has evolved from poliovirus monitoring in the mid-2000s to a sophisticated system for tracking SARS-CoV-2 and emerging pathogens. Led by the Gastroenteritis, Measles, and Environmental Virology Group at the Dr. Jose Maria Vanea Virology Institute and supported by international collaborators, this early foundation enabled a rapid COVID-19 response. In 2020, the team launched citywide SARS-CoV-2 wastewater surveillance to monitor community-level spread and variant emergence. Cordoba City was divided into 7 sanitary zones with weekly grab samples collected from manholes in 6 zones and from the main treatment plant, Bajo Grande, which serves half the city. The samples were analyzed at the Virology Institute using RT-PCR. To interpret results, the team developed a model estimating the number of people shedding virus using viral shedding assumptions and calibrated with Ministry of Health case data. This allowed for normalization and comparison across zones. The system provided early warning with SARS-CoV-2 RNA increases often preceding clinical outbreaks by up to 2 weeks. It also enabled early Omicron detection and informed testing, isolation, and triage measures. Building on this success, the team identified AKI virus A1, an emerging gastroenteritis pathogen, in nearly half of wastewater samples and over 20% of pediatric cases. They are now developing poliovirus detection protocols with regional partners as part of South America's effort to strengthen environmental enterovirus surveillance during the final push for global polio eradication. Thanks. Stephanie, are you around? Okay. Do you have the why don't you come up and introduce Reba? Sorry. Oh my gosh.
Oops. All right, up next, we're going to move into our third session, first for the afternoon today. We'll be talking about bridging the gap and wastewater surveillance in low resource settings. And so I want to bring up Ms. Riva Katz. Ms. Katz is an experienced epidemiologist, there we go, with over 40 years in public health, and she's helped to lead the city of Anchorage's public health efforts impacting 45% of Alaska's population and established its wastewater testing and disease surveillance program. So with that, please, let's welcome Ms. Katz.
The 40 years is not as great as it sounds. I started when I was 5.5. My job is to moderate a session that is very different from the sessions you heard this morning. We're going to talk about low resource areas. That's areas like Anchorage that had zilch to use when they start their wastewater program. So my job is really to introduce the speakers, stay out of their way, and try and keep them on time. But if you'll give me just a minute to set the mood for you. As was mentioned, I am trying to retire, but I'm from Anchorage, Alaska, the largest city in Alaska. We have about 42% of the population. It's only about 280,000 people, okay? We live in a land where COVID was not a disease, it was a political statement. That was your identity. You believed in it or you didn't. Okay? When it started to blossom, however, the mayor of Anchorage appointed me the city's epidemiologist. Now, for those of you who are also epidemiologists, I know that sounds weird. I was a political appointee, the only epidemiologist in the city. So I had a great title. I was the highest public health professional in the city, the only epidemiologist, the second highest medical officer in the city, with nebulous authority, a desk, a parking space, no budget, no staff. And COVID may or may not exist, depending on the group you're talking to, okay? And you add to that no data, because if there's no COVID, there's no need to report anything. And if you report some numbers, that might mean there is COVID, which could be confusing to the public. So with that, I tried to start a wastewater, well, can't say surveillance in Alaska, a wastewater epidemiology program with no money, no actual authority, just some waving of my hands that says I'm important, I'm doing this. We got help, suggestions from several of you here in the audience who made it possible. We weren't allowed to take stipends. or grant money. The state wouldn't support our efforts, so we got no CDC money, no ELC money. We couldn't even use volunteers. That's against the union contract. So there was just me and a few people at the wastewater treatment centers who were willing to sort of sneak out some samples when nobody was looking and believe that we could get this started. Not only did we get a program up and running, but we at the time were the only independent city accepted to news with a population well under 1.5 million. We're no Houston, we're no New York City, but the state wouldn't join, so they let us join because everybody thinks Anchorage is the capital anyway. So that's how we got going. The program is still running today. Okay, a little shrunken, but it's still going. And to give you an idea about what low resource areas look for, believe me when I say I wish I had genomics. I wish I had anything remotely resembling genomics, but they don't have that in Alaska. So what we use for our goal is, right before I came here, I got phone calls from 3 people who contacted me personally to let me know that my posting of the wastewater data from the recent scan report and what it meant convinced them to get COVID vaccinations, okay? Doesn't sound like much, but for us, that's a big deal. So now that you're sort of in the mindset, let me introduce our first speaker. And I know you're supposed to read the bios online, but for this one, you have to cheat a little bit because his bio is almost blank, okay? So go to Stanford and look up the profiles there and read about his amazing background that's not in our bio, okay? So I'm going to turn it over to Dr. Jason Andrews from Stanford to get us started.
All right, sorry. Good afternoon, everyone. Thank you to the organizers for the opportunity to give this talk. I'm going to be talking about low-cost, scalable approaches to wastewater surveillance in low-resource settings. And at the risk of sounding pedantic, in a conference that's about surveillance, I thought that it was important that we actually define what we mean by public health surveillance as we start talking about low-resource settings. And I think this is important because we often conflate surveillance with research, and particularly in low resource settings where there's often a lot more research on wastewater epidemiology than there has been surveillance. So by surveillance, what we mean is the ongoing systematic collection, analysis, and interpretation of health-related data essential to planning, implementation, and evaluation of public health practice. And we distinguish that from research, which are focused short-term endeavors often that are many times externally funded, or we hope externally funded, to measure health-related data, often using some of the same types of methods that we use for surveillance, but with the goal of creating knowledge that can be generalizable. And I come from academia. What my lab does is research. We create tools and test tools for surveillance, but we're not really doing the surveillance itself. That's done by public health departments, ministries of health, and so forth. And the reason I'm belaboring this distinction is because the tools that we use in research are often not feasible for use in public health surveillance. This is particularly true in resource-constrained settings. So when we don't have these external resources, we often can't do the various kind of sophisticated things we can do whenever it's constrained in time and place if we want to do this at scale. And surveillance in these kind of settings, try to hold. Can you hear? There we go. Hope that's better for everyone. Okay. So surveillance, particularly in resource limited settings, needs to be affordable, accessible, and scalable. And I'm going to give the example of Nepal, where I've been working for more than 20 years, and we've been doing research involving many elements of epidemiology. And in Nepal, healthcare expenditure per capita is about $75 a year.
That's a substantial improvement from about $11 a year when I started to work there. And this is a clinic from one of the communities where we work in Nepal. In a recent SARS-CoV-2 wastewater sampling program that was established in Kathmandu published estimates of the cost of their program and estimated that it was about $120 to $175 per sample for that program. In other words, it was about twice the annual per capita expenditure on healthcare for each sample that was collected and tested in that program. And just to give some comparison, in the United States, our healthcare expenditure is about $14,000, $14,500 per capita. And we heard this morning about some of the challenges in demonstrating the value and the cost effectiveness of wastewater surveillance in the United States. But imagine if the cost per sample was around $15,000 to $20,000 for each sample in these wastewater-based epidemiology programs, right? We would not consider that to be likely to be fundable, sustainable, cost-efficient use of resources compared to other healthcare expenditures. And this is really the case in countries like Nepal as well, where paying twice the annual per capita health expenditure is really just a non-starter. It can be done for research projects, and we often do this for kind of focal research projects, but not done at scale. A further challenge is that the majority of the population lives in communities like this, as you can see here, which are non-sewered communities that are often remote, where we don't see molecular biology capacity. We're not able to collect samples and get them same day to laboratories for DNA extraction and processing. And so we need to be thinking about surveillance systems that can serve this type of population. And it is absolutely the case that surveillance is needed in such settings. In fact, arguably, the surveillance gaps in such settings are much greater than those that we face in the United States. And the surveillance gaps there further amplify other forms of inequities. And just to give an example of that here, when we have gaps in disease surveillance, that often leads in inability to support introduction of interventions like vaccination. Not introducing vaccines creates further disease inequities, which strains health system strains mean that there's no resources to do surveillance, and we see the cycle continuing and continuing. So surveillance has the potential to try to break this cycle, but it must be actionable. And I think this is certainly true whether we're doing it in a low-income setting or in a high-income setting, but in low-income setting, the stakes are higher where the resources are more constrained. And so I want to turn and give a really concrete example from the work that we've been doing in Nepal and elsewhere in South Asia over recent years, which is around typhoid fever. Typhoid fever is an invasive bacterial infection. It causes around 10 million illnesses per year. The vast majority of those occur in South Asia and in Africa. It's spread through fecally contaminated food and water. Untreated, the case fatality rate is 10 to 20%. And in recent years, we've seen major advances in the fight against typhoid fever. So we now have new conjugate vaccines, which are highly effective. They confer about 80 to 85% protection against typhoid fever. In 2018, the World Health Organization reviewing these data recommended that typhoid vaccines be introduced in countries that have high burden of typhoid fever. And shortly thereafter, we began to see rollout in many high burden countries in Pakistan, Liberia, Zimbabwe, Nepal, Malawi. The cost of these vaccines is about $1 a dose. So it is highly cost effective in settings that have a high burden of disease. Unfortunately, the vast majority of countries in which the burden of typhoid is great have not yet introduced vaccines. So we've had a handful of introductions of this cost-effective vaccine, but most countries are not introducing it. And they're not doing so primarily because there is a lack of data on typhoid burden. Typhoid is difficult to diagnose. Most countries don't have strong surveillance systems. They're not able to demonstrate to Gavi what the burden is. Typhoid environmental surveillance has actually been around for more than 100 years. This is a study from the late 1800s, shortly after the typhi bacillus was discovered, in which testing and demonstration of it in drinking water was done. In the 1950s, there were examples of doing sewage surveillance to identify people who are chronic carriers shedding typhi. And in the 1980s, wastewater surveillance was used in Chile to understand transmission patterns and actually ultimately address a very high burden of typhoid in Santiago. Unfortunately, the methods that were used in these periods were largely culture, and culture has very poor yields. Recent groups that have been trying to replicate this with wastewater surveillance have found less than 1% yield, despite doing this in very high burden settings. Real-time PCR has much greater sensitivity, but still has a modest yield overall, and the costs are considerable. So published cost around typhoid environmental surveillance is several $100s per sample. So our group has been focused on an alternative approach, thinking about how we can improve the sensitivity, decrease the complexity, and decrease the cost. And we've done this through looking at Salmonella typhi bacteriophages, which are viruses that infect Salmonella typhi. Bacteriophages are the most abundant organisms on the planet. They're far more abundant than the bacterial hosts, so we have better chances of detecting them. They're also very specific. They're specific to the serotypes of typhi. They don't infect other serotypes within the Salmonella enterica species, much less other bacteria. And they're very stable at room temperature. So we can actually keep them for a long period of time. They're easy to detect using really simple, well-established microbiologic methods. And so to test this proof of concept that we could test for bacteriophages as a way to surveil for typhoid burden, we did initially pilot work in Nepal. Here is collection of samples from surface waters. Again, there aren't formal sewage networks, but these are sewage-laden surface waters. And we used an approach that you can see here where we collect the water and we expose Salmonella typhi plates and look for plaques that appear. It's a very simple, well-established method for identifying the presence of phages. And when we did this in Kathmandu and several communities around Nepal, what we found was that we detected a lot of the bacteriophages, particularly in the high typhoid burden communities. We had about 50% detection overall in Kathmandu and even higher in the center of Kathmandu, tracking well with disease burden. We saw very low positivity out in rural areas and in other cities that had low burden of Salmonella typhi. And a similar study was done in parallel in Bangladesh that generated really consistent with the results of this. So demonstrating the proof of concept that detection of the bacteriophages would track well with burden. We also found that the phages that we detected, the several hundred of them, were very specific to Salmonella typhi. They don't infect other Salmonella serovars, they don't infect other bacteria, and in fact, they only will infect Salmonella that contain a VI polysaccharide capsule, which is common to all Salmonella typhi. And when we test against a knockout strain, they don't infect. So we know exactly what causes the specificity for typhi. This approach worked really well, but pouring agar plates and testing them is not necessarily the most scalable thing to be doing in resource-constrained settings. And so our more recent work has been trying to simplify this assay, make it done with reagents that can be transported without cold chain, reduce the costs, reduce the complexity and training to do it. And so this is what we've arrived at now, which is a colorimetric version of the phage assay, where we collect the water sample. We just need 1 milliliter of water. We expose it to a standard Salmonella typhi strain, which amplifies any phages that would be present in the water. We then filter it and add the strain, a lyophilized strain again, together with a color reagent, resizurin, and incubate again. The entire procedure takes about 5 or 6 hours. And after that, we get a color readout. And so if there are not bacteriophages in the sample, the bacteria will grow. They will convert that purple to a pink, demonstrating the absence of the phages. If the phages are present, they will inhibit the bacterial growth and the sample will remain purple. And so you can kind of see, I'm able to indicate it there. The samples on the right that are purple are positive samples and the pink ones are the negative samples. So it gives a really robust, simple to interpret readout. We found through extensive testing that this has 100% concordance with an auger overlay method, has a very low limit of detection of about 28 plaque forming units per milliliter of water. We've demonstrated that we can transport the samples at room temperature and they're stable for at least a week. In fact, we've collected samples and hand carried them across the world. We've FedExed them across the world and been able to test them in other laboratories. And so you can have unprocessed samples that are really easy to transport and test. The reagent costs for this assay are about $2.40 per sample. That can come down with bulk purchasing. And there's no sophisticated equipment needs. We don't need real-time PCR machines and clean rooms and so forth to do the molecular biology. We can really do this in any laboratory that has an incubator. We've even tested this with a low-cost electricity-free incubator that can be made for less than $50. So I really believe that this kind of testing can be done in almost any setting. We have further validated through testing in Niger and in Ivory Coast, as you can see here. Again, these are non-sewered settings. So these are surface waters that are contaminated with sewage. In Ivory Coast in particular, there have been no Salmonella typhi surveillance studies done in the past 30 years. So we have no blood culture-based data at all to work with. We don't know what the burden of typhoid is there. But through this approach, we were able to document in a short period of time a really high abundance of the bacteriophages in Abidjan, the capital, indicating a considerable burden of circulating Salmonella typhi. We similarly found it in Niamey. We found a lot in Kathmandu, and we did not find any positive in Campo Grande, Brazil, which is a city without typhoid fever in South Asia. This in Brazil, this was a negative control. We're currently doing prospective comparison with clinical data from a cluster randomized vaccine trial in Vellore, India. This again is an open sewered setting, and you can see here the sewage networks that are mapped. We're comparing against both clinical data as well as real-time PCR data. And so we'll have, at the end of this, hopefully some validation that this tracks well with local incidents in the community. So to conclude, the need for improved disease surveillance is even greater in LMICs, where data gaps are really amplifying disease inequalities, putting barriers to implementing interventions that could be highly effective. Wastewater surveillance, I think, really could help us close this gap, but in order for it to be scalable in LMICs, we need to have low-cost methods that can be performed in labs with minimal equipment, focused on pathogens for which there are known and identifiable interventions. I don't think we can afford to be making an argument to collect data for data's sake. It's really got to be linked with clear interventions. I think I'm back. We found that this colorimetric approach for detection of bacteriophages was sensitive, it was highly specific. It enabled us to distinguish settings with high versus low or no circulation of Salmonella typhi, including in settings that had no demonstrated burden because of lack of existing surveillance infrastructure. And that can be used to help inform vaccine introductions. And I really believe there's many opportunities that we have for innovation around reducing the costs and complexity of wastewater surveillance to make it more accessible in resource-constrained settings. So one of the challenges I would pose to this audience is to think about how we can take the incredible tools that we've heard about today and that all of your groups are developing and try to reduce the cost, reduce the complexity, and make those more accessible and scalable in resource-limited settings. I just want to acknowledge my lab and acknowledge our many partner labs around the world who contributed to this work. And thank you again for the opportunity to share this work.
Thank you. So with this mic, I can't sing. We're going to bring up Co-Alaskan Brian Leffert is the Director of Public Health at an area very different from Anchorage. He's in what we call the YK, the Yukon-Kuskokwim area, which is a native tribal health system representing, I believe it's 58 native villages. So he's also going to talk about using wastewater surveillance in a low resource area.
Hi, thanks. Can you hear me okay?
Yes.
Okay, great. So I'm Brian Lefferts. I'm the Director of Public Health for the Yukon-Kuskokwim Health Corporation. Also working with me on this project were Alyssa Leary. She's the Environmental Health Services Manager for the Yukon-Kuskokwim Health Corporation. I think Alyssa's online. She's going to help with answering some questions if people have any. And Dr. James Keck, he's a clinical researcher with the Alaska Native Tribal Health Consortium in Anchorage and has been an advisor and a wonderful partner throughout this. So next slide. I think we might have skipped two. Can we go back one? Sorry. Okay, sorry. Thanks. So Yukon-Kuskokwim Health Corporations, commonly called YKHC, is a tribal health organization. We administer comprehensive healthcare delivery to, as it was mentioned, 58 federally recognized tribes in southwestern Alaska. Each of the communities in our service area is home to a federally recognized tribe, and their governing council has authorized YKHC to provide healthcare and public health services on behalf of the Federal Indian Health Service. Our delivery system includes smaller community health clinics in most of the remote villages. Some of the larger villages operate what we call a sub-regional clinic, a little bit larger version of that with staffed advanced practice providers. A regional hospital in Bethel with an emergency room and inpatient services, dental, optometry, behavioral health, etc. We also have health promotion, disease prevention, and of course, environmental health services who led this project. Next slide, please. So this is a map of our region. Like I mentioned, it's in southwestern Alaska. Something unique about us is the area is about roughly 75,000 square miles. So it's about the size of one of the Dakotas, and it's home to about 30,000 people. 80% of which are Alaska Native, and outside of the hub community, Bethel, the Alaska Native population's closer to 95%. And something unique is none of the road, there is no road connecting Bethel to the mainland or Bethel to any of the surrounding villages or connecting the villages between each other. So the only way here is by airplane, and the only way for us to deliver services back and forth to the communities is by airplane. You can see a photo there, though, of road signs to some nearby villages. That's on the ice road. In the wintertime, the river can freeze solid enough that we can get plow roads and have truck traffic, but that's only available when the river's frozen. Next slide. So our project took place in Bethel. Bethel's the hub community where the hospital is located, and it's home to about 6,400 residents. We have a combination of a couple different ways to deliver water and sewer services. We have pipes, which are similar to pipes in the lower 48. Here they're delivered in Arctic pipe. You can see an example of that in the bottom right photo. That's insulation that surrounds the carrier pipe. And then it's above ground. You can see by the middle photo at the bottom. This is because we're on discontinuous permafrost that freezes and thaws and moves a lot, and so we can't bury a lot of our piped infrastructure, so it's above ground. We also have hauled services to about half of the homes, and those are delivered by 3,000-gallon trucks. You can see a photo of that in the bottom left. We have water trucks that deliver water to the homes, and then, of course, a different truck that hauls away the sewage. The frequency varies. Customers can choose how often, depending on the size of their tank and how many people live there. But the most common is to have 1,000 gallons every other week. Next slide, please. So this is a satellite view of Bethel, and I think you might have to, if you could Okay, yeah. And so this is where we're sampling, the sampling from the lift station. There's a photo of the lift station and you can see a little arrow of where that's located. The 2-cell wastewater lagoon that it gets piped to is up at the top. And these are the areas that are circled in green are the areas that pass through the lift station where we did our sampling from. I think if you click one more time, it'll show. So these subdivisions are not included in the sampling. That's because the water sewer trucks or the pipes pump directly to the lagoon, and there was no easy location to sample from for those homes. So but our wastewater sampling, actually, we later found out it does include that middle circle there up at the top. So it includes, we think about 2/3 of the wastewater in town is incorporated into our sampling. Next slide. So we wanted to do this project similar to, for reasons I'm sure that are similar to why people want to do wastewater surveillance lots of places. We were kind of slow to start this because throughout the pandemic, we had a really robust participation in monitoring and reporting of COVID-19 cases. Even home tests would be reported to us because the only way people could get home tests were to go to one of our clinics. We don't have a pharmacy or CVS where people could go purchase things, these home tests. So people would come and get them from us and then report back to us what their results were and ask for advice. And so we had really high reporting, but as people even stopped doing home testing, we started seeing less and less understanding of the rates of COVID circulating in the community. And so we began looking to ways to monitor for the respiratory virus burden in the region. Next slide. This is important to us because we were disproportionately affected by COVID. You can see here, we had several times throughout the pandemic some of the highest rates of COVID-19 in the United States. Some of that could be due to the reporting. As I mentioned, we had a lot of people like to report to us, so I'm sure that led to some elevated rates. But also we saw much higher rates of hospitalizations and deaths. You can see there from the graph on the right, how disproportionately Alaska Native people were affected by COVID-19 in Alaska. So it was interesting for us to continue to monitor for COVID. Next slide. We also wanted to find something that could help us to monitor for respiratory syncytial virus. RSV is something that has disproportionately impacted our region for many years. We've had the second highest RSV infant hospitalization rates in the world for many decades. And so we have been intent on finding any intervention steps that we could think of that would help us in our attempts to help control RSV, which I'll go into a little bit more later. So next slide. Our motivation for the system that we came up with utilizing Gene Expert PCR came from a Canadian pilot project in Yellowknife, which we reached out to the authors of this study who are doing some SARS-CoV-2 monitoring using Gene Expert and asked them for some advice on, we were impressed by their results and this sort of like led to our project. Next slide. So to collect samples, we used a Moore swab. This was suggested to us by our partners, Dr. James Keck, I mentioned earlier, and his colleagues at the University of Kentucky, who had been using a Moore swab to do some wastewater sampling in Kentucky, and then also some projects in Africa. And it's just a really simple tool because you can just take some gauze. You can see there we have a roll of gauze, and then we open it up and then unroll it, loosely fold it over itself, and then secure it with a really heavyweight fishing line. And that's all we use to collect our sample. Go to the next slide. So we take that Moore swab and we place it down into the lift station. You can see by this diagram, we have a weight that's attached to a chain. The weight sits on the bottom of the lift station, and then about a foot up from the weight, we attach the Moore swab fishing line, and that keeps the swab itself from just sitting on the bottom of the lift station, and it sort of floats around in the lift station, but it's short enough and attached to the chain in a way that it keeps it from getting caught into the lift station pumps. So we just use this hook, and we place it down in there, and then when we're ready to retrieve it, we just grab one of those hooks and pull it right back out. Next slide. We typically leave the swabs in for about 24 hours. The frequency of that depends on the funding. Initially, we didn't have a lot of funding, so we were sampling every few days. But as we got more funding, we started leaving the swabs in for 24 hours, and then on Friday we leave it in over the weekend and grab it on Monday. Next sample. Next. So this is a little bit about the process. So we go to the lift station, a couple different staff go with our supplies in a bucket, and we open up the lift station, place it in. Next slide. This is a photo looking into the lift station. You just pull the chain up to the surface. You can see us there attaching it with, there on the left, it's the hook that's being used to grab the chain. We got the chain up to the top. You can see us attaching it to the chain, and then we repeat the process and drop it right back down in. Next slide. Oh, yep. You can see us just tying it on there. Okay, that's probably the end of the video. Okay, and then go to the, next slide. I'm sorry, the videos are kind of being funky. Okay, so this is us after when we pull the swab up, we just carefully place it right into a Ziploc bag. So somebody opens up a Ziploc bag, the second person sets the more swab inside of it. We use some scissors to cut it off. And now the swab's inside of a Ziploc bag. We cut the bottom corner of the Ziploc bag, and then we just squeeze all the liquid out of the swab and into the sample jar. And you can see the photo on the bottom right is just the liquid that we retrieved from the swab sitting in a sample jar. And then we drive across town, being a remote area that just takes a minute or two, and we're able to get to our lab. Next slide. Yep, so that's us just squeezing it into a jar. Okay. So originally this is our wastewater lab. We've since moved to the lab over to our office, but we had a warehouse where we started this process. This is a photo of it. Up at the top, you can see some of our concentration equipment. We process these on the Cepheid respiratory platform, looking for flu A, flu B, RSV, and SARS-CoV-2. Initially, we also ran side by side a concentrated version with a non-concentrated version. And you can see there in the photo at the bottom, the sample jar is just sitting in front of the Cepheid Gene Expert cartridges. And so it doesn't take up a whole lot of space. As we process those, both different versions, and compared them side to side, we realized that they were very similar. And so we were able to abandon the concentration step and just go with running the direct collection sample. We just shake it up, let it sit for a few minutes, and then we can draw off the top of the sample and place it right in the back of the Cepheid cartridge and stick it into the PCR machine. Next slide. So this is a photo of our lab now. Doesn't take up a whole lot of space. Those are the PCR machines, pretty small. Each of those holds 4 bays, so we can stick one of those cartridges you saw inside of that after we've drawn 300 microliters off the top, put it in the cartridge and place it in the PCR machine. One of our partners calls this the Keurig of PCRs, because it's just a real simple process, and all the complicated pieces are contained within the cartridge. Next slide. So these are some of our results. This shows a graph of the SARS-CoV-2 from October 2022 when we started through May of last year. We're seeing similar results now. It compares the clinical cases that have come to YKHC there in green to the wastewater concentration. And you can see a lot of the spikes line up, and this is by week over that period of time. And so really visually, you can see a really strong correlation between the spikes we saw week to week and the dips from the wastewater as compared to the clinical cases, really matched up. We're very pleased with that. Next. We saw something very similar for influenza A. This is the inverse CT cycle threshold values from the PCR machine in blue compared to the number of clinical cases in green by week for the same time period. And then next slide, as well as RSV. So we're very happy to, as I mentioned earlier, RSV's monitoring is really important to us, and we're excited to see strong correlation between the inverse CT value from the Cepheid Gene Expert results to the clinical tests that were being performed. We were relying on a lot of federal funding to purchase these tests for nearly everybody that came into the hospital for SARS-CoV-2. And so over this time period, we've been testing lots of people that have come into YKHC who had any respiratory symptoms that may, as the federal funding goes away for SARS-CoV-2 and there's less of a clinical reason to test everybody that comes in with a respiratory symptom for this, we may need to in the future more heavily rely on wastewater sampling. But it's good to know that when we're sampling lots of people, there's strong correlation again between these two things. And then next, we, like a lot of places, didn't have a lot of influenza B in 2022, 2023, but then the following year, we did start to see it, and we were happy to see that there was correlation again between even flu B and the wastewater as well. Next slide, and this is just all of them combined, and we'll skip on to the next one. So a few challenges and lessons learned. I think one of the things we were most excited about was that we were able to skip the concentration procedure. That was a lot of extra work, and it was good to know that we could skip that and still have a lot of confidence in the results that we were seeing. Other little things, we've changed the way we attach the swabs. We've learned how frequently we have to order supplies, and even being Alaska, we occasionally find that the lift station doors are frozen shut. But a lot of those are just process things that we've been able to improve as we move on. Next slide. I think a lot of people might be interested in this. So the startup costs for this were $30,000 for the Gene Expert machine that we were using. That was just for one of those 2 4-bay units. The concentration step was about $20, which we've gotten rid of. And the Cepheid cartridge, which runs for which we can use to test for flu A, flu B, RSV, and COVID, was about $70 per sample, which comes to only about $350 a week or $4,200 a year. So not a really expensive to implement this sort of approach. And it doesn't take a whole lot of time either. So processing the sample takes about 45 minutes a day, and then another 15 minutes to analyze the data. So less than an hour of time. And the placing the swabs is a pretty short step too. Next slide. And we've used this for public health decisions as well. For example, in the past, we had been holding off on wondering when we were going to start our annual flu drive, and we started seeing flu in the wastewater. We had been planning to do the flu vaccine distribution in October, but once we started seeing flu in the wastewater a little ahead of the clinical testing, and we saw a massive spike right away, we knew that we needed to push up our flu vaccine drive. I also mentioned that RSV is really important. Some of you may know of nirsevimab. It's a monoclonal antibody that's now available for infants in their 1st and 2nd year. And so the timing of that, it can wane over time. It's not it's an immunization, but not a vaccine. And so it can wane fairly quickly. And we really want to hold off on starting to administer that each fall until we really start seeing a lot of RSV again, so that we can maximize peak protection while we have the peak RSV season. And so we rely pretty heavily not only on wastewater, not only to know when to start administering nirsevimab, but then when we stop using it at the end of the season, which we relied on wastewater RSV data just this week, actually, to make a decision about when to stop administering nirsevimab in the region. So next slide. We placed all of this on our website. We update it each week for the public, and then we also share it with clinicians around the organization. Some things we're excited about: we're expanding now to 20 surrounding villages. They're sewered communities. About a third of the homes in the region lack indoor plumbing, so we're somewhat limited to where we can sample. We're thinking about how we could expand to the unsewered communities and with partnerships to the schools, but right now we're starting with an expansion to some of the surrounding sewered communities. And then we're also using it to surveil for other pathogens. Gene Expert has a TB test and a norovirus test, and we've actually successfully detected TB in a couple different locations using this method, which we're excited about since we have some extremely high tuberculosis rates in the region. We actually, only get about $300,000 a year in TB specific funding. So having a tool like this to identify communities where there's maybe an outbreak that we're not aware of can really help with knowing where to allocate resources. This is an example of our website and that we put up for the public, and they can just see each week, like as I mentioned, we post what we're seeing and some recommendations. So our project partners, this is everybody in the Office of Environmental Health who contribute to the project: Alyssa, Sarah, Mike, Jenny, Christine, Bob, and myself. Next slide. And I think that is the end of my presentation. I guess I'll add one more thing as far as next steps. Cepheid has announced that they're replacing the COVID or the respiratory platform, which tests for COVID, flu A, flu B, and RSV with a larger respiratory panel. So we're really excited to be able to use the same process starting this fall to test for adenovirus. In addition to those, they're adding adenovirus, human coronavirus, human metapneumovirus, rhinovirus, parainfluenza, bordetella pertussis, which is really exciting. For us, we're having, like a lot of places, a lot of pertussis cases, parapertussis, and mycoplasma pneumonia. So excited to just see what the future holds, and not a lot of effort to get a lot of information from it. And that's the end of my slides.
Now I'd like to introduce our last speaker. Mr. Mohammed Islam is a doctoral student at the University of Virginia in civil and environmental engineering, and he specializes in infectious diseases and wastewater surveillance in low resource areas.
It takes a minute to reboot. Is it on? It's
Oh, sorry. Sorry about that. Good afternoon, everyone. Today, my talk is on the implementation of sewage surveillance of infectious diseases in Dhaka, Bangladesh, which is very low and middle income setting. And this is a very highly collaborative project among the University of Virginia, Imperial College London, ICDDB, which is a public health research institute in Dhaka, Bangladesh, and IEDCR, Institute of Epidemiology, Disease Control and Research in Bangladesh. And I forgot to mention, this entire project was led by Professor Mami Taniyuchi, who is sitting in the crowd, who is my advisor. So thank you for giving me this opportunity to talk about this, Mami. So some of the key points I'll be covering throughout my talk is how important it is to engage with the public health stakeholders and also the government agencies who are responsible for the decision-making. Also, then how we set up the sewage surveillance in a city like Dhaka, where we didn't have any formal sewage system. And then after we set up our system, how we tested the performance of the sewage sites, how they are doing. And then we developed an integrative approach to detect multiple targets, such as poliovirus and vaccine preventable diseases, antimicrobial resistance genes, enteric pathogens, etc., in the sewage. And also the public health impact of the sewage surveillance during the COVID-19 pandemic. So to start with the public health stakeholders engagement is highly important. So engaging with public health stakeholders was very crucial before we started our study. So that was like, we had to make sure everyone was on board upfront before we started anything. So we were successful to do that. So these are the public health stakeholders listed here. The IDCR was the major public health partner with us in Dhaka, Bangladesh. And we had regular dissemination meetings with them for the study updates. And we also updated the Prime Minister government COVID-19 task force on a weekly basis using summary reports. And also we developed a dashboard using that we used to disseminate our data for the general public, the public health decision-making people, and also for the government COVID-19 task force. And then we also, these dissemination meetings, our updates were covered by the mass media, the local newspaper, also the local channels for public awareness. So this entire process was highly, highly important before you start. So this is an overview of the sewage surveillance we have in Dhaka now. So we started in June 2019 with 12 sites in Dhaka, which is in the, you can see in the map, it's the middle income area. And in that one, we surveillance for the polio, the vaccine preventable diseases, AMR, and other enteric pathogens. And then the COVID-19 pandemic happened. We expanded our sites to 33 sites in Dhaka for low, middle, and high income areas in Dhaka. And then we also expanded in Dhaka, where in the southern part of the Dhaka, where we had very few numbers of clinical cases being reported. So we expanded our sites there. So we had 51 sites at that time up and running. And currently, we have 51 sites across Dhaka city for multi-disease surveillance, where we are conducting surveillance for RSV, measles, cholera, vaccine preventable other diseases, SARS-CoV-2, etc. So before we started everything, we had to, if you establish a sewage surveillance, you need to understand what is the sewage system looks like. And in Dhaka city, there was no formal sewage system. We had only one, we have only one sewage treatment plant functional that can only treat approximately 20% of city's sewage system, and 80% goes to the river untreated. And most of the people who are connected, no one knows who's connected, what is the catchment. So that is unknown to us at that time. So this is the picture. The top map is the high income area and the bottom map is the middle income area. So we reached out to the Dhaka Water Supply and Sewage Authority for these maps. So all we got is some maps, I mean the sewage maps for the high income areas, you can see in the black lines. But for the middle income area and also for the low income areas, we couldn't get any maps. So what we did, we had to go in and fill those maps. We had to map this thing by ourselves. So what we did, so initially we thought we could use very traditional ones, use GPS-based devices, and you can map all those networks in the area. But in Dhaka, it was really, really difficult for us to get the satellite connections. So we had to improvise the whole methodology and did it a little bit of manually. So what we did, we used paper-based maps. So we printed the paper maps and went to the field and drew like sewage lines on the paper maps and walked on every roads and streets for probably like 2 months. So we did that. So we drew the lines and also we collected information from the downstreams and the upstreams of the stream, and then also the flow direction of the sewage line and the outlets where we could set up our potential sample collection sites. And then this all information were digitized using ArcGIS Pro, and we made a digital file, shapefile format. And then we collaborated with Novelty, which is our mapping partner, which is a mapping company based in Geneva, Switzerland. So what they did, they used our shapefile and the digital elevation model of Dhaka city and the population data from demographic survey we had and also from a World website. So they integrated all those information together and made an online interactive map for us. So this is the online interactive map looks like. So on the screen, you see these blue lines are those Suez lines that we mapped. And the digital elevation layer and also the population density layer was overlaid on top of this. And there are several tools on this map you can use, but you can see on the right side, it says site creation helpers. So you can use this and drop this pin anywhere on the network, and it will create a Suez sheet for that point, and also it will give you the catchment population living within it. So we used this one tool and selected many sites at the beginning from this interactive map. And then we went to the field. We also considered some other characteristics for site selection. For example, the catchment site. So at that time in 2019, we only knew about the polio environmental surveillance that you need at least 150,000 population within the catchment to get poliovirus in your sample. But we are also doing other enteric pathogens. So we didn't know what is the ideal catchment should be. So what we did, we selected sites that had a catchment range from 1,000 to 600,000 population. And we also made sure that the sites we selected had easy access for the field people who go in and collect their samples. And then that should have water flow all the year round. And no waste, industrial waste should be mixed in your samples in the site. Along with all those, we also measured the sewage's physicochemical properties using aquarid probe, which is in the middle. So using this device, we measured the properties listed on the right side of the screen. So we wanted to know which one of these properties are actually associated with the detection of the pathogens you're looking for in the sewage. So that is the idea. So using all these, we selected some sites in Dhaka. And then now that you have your sites, you need to make sure your sites are working well. So the performance testing, right? So we did that using a bivalent oral polio vaccine campaign in our area. So this bivalent oral polio vaccine is a mucosal vaccine that was given to the children under 5 years old in our area. And after administration, the child will shed the vaccine virus strain through stool, and you can detect it from the wastewater or sewage. So on the screen, you see the graph. The columns are the area, and the rows are the sites in those areas. So there were 12 sites up and running at the time. And there's a vertical line in each box. That is the timeline when we vaccinated the children. So you can see for most of the sites, there is a sharp rise of the vaccine virus strain 1 and 3 for most of the sites. But for some of the sites, there was no detection from those sites. So those sites were not performing very well. So that was a performance test for the sites we selected. That's how we did it. And then that project was going on. And then a COVID-19 pandemic hit Bangladesh in March 2020. And we pivoted our entire sewage surveillance system to detect SARS-CoV-2 in the wastewater. So when we did that, we found that our sewage data, the first detection in the sewage data of the SARS-CoV-2 was at the same time when the first death case of a person in Dhaka at the same time. So, and then we got more funding to do more wastewater surveillance in Dhaka. So we expanded our sites, as I mentioned earlier, in Dhaka, and did sewage surveillance for SARS-CoV-2. And you can see on this plot, the purple line, the top line is this, it says ES data, means the sewage data, the SARS-CoV-2 concentration in the wastewater. And the bottom one is the geolocated clinical cases in our area. And you can see they both track each other very well. But initially, because we had very few number of clinical cases coming in, so the correlation between the sewage data and the clinical cases were not that strong. But with time, when we have more clinical cases coming in, so then the correlation got stronger. Then we looked at the data at area level. As I mentioned, the low income, high income, and middle income areas. So each one of these columns are the areas. So the first three are the low income, the next three are the middle income, and the last two are the high income area. And you see, if you look at the top panel, which is the clinical cases, only if you look at the right side in the red box, the more clinical cases are actually coming from the high income area. But when we investigated, we got that during that time, the tests in Bangladesh for SARS-CoV-2 were not free. So not everyone could afford the testing on a regular basis. So only the high income people could do that. So there were more clinical cases being reported from that area compared to the low income and the middle income. That's why you see a lot of clinical cases in that area. But if you look at the sewage data in the bottom, in each area, the concentration of the sewage, the viral load in the sewage is the same, with the same intensity. So this is where you can say the sewage surveillance is actually unbiased regardless of the socioeconomic status. And also it gives you a very powerful secondary data set to look at. So again, that was also going on, and then COVID started to recede. In August 2023, then we shifted our focus back to the multi-disease surveillance. And in the new study, we are conducting surveillance for RSV, influenza, measles, SARS-CoV-2, the outbreak serotype of Vibrio cholerae, that is 01 and 0139. And we are also conducting genomic surveillance for measles and SARS-CoV-2 in Dhaka now. All right. So this is very preliminary data from our multi-disease surveillance. This is the cholera surveillance data from Dhaka. And as I told you, cholera, Vibrio cholerae 01 and 0139 are the two serotypes that are responsible for the outbreaks. And for the past 10 years, Vibrio cholerae 01 is the only responsible serotype that is causing the outbreaks in Dhaka, so that we looked into the 01 very closely. See, on the graph, you see the vertical, these darker gray, the bars are the geolocated clinical cases, the cholera cases from our area. And there's a blue line, which is a clinical incidence that is smoothed. So there's the clinical data. And the red line is the Vibrio cholerae CTXA, which is a toxin gene that comes from Vibrio cholerae, any Vibrio cholerae in the sewage. And the green line is the Vibrio cholerae 01 serotype that we found in the sewage. And you can see both CTXA and 01, they trends together very well. They have the same trend. And both of these 01 and CTXA have the same timing of peaks with the clinical cases. So we were able to show that our surveillance system was able to track the cholera outbreaks in Dhaka. But now we want to see that if there is any correlation, if we can find a lag, or if our system is acting as an embryonic system or not. So that's a work in progress now. So Isabel Blake from Imperial College of London, which is our modeler and analyst of all this data, she's doing all this thing. Now that we are looking our data more closely, I kept saying more closely, we're thinking is normalization of our data necessary or not? And if we could use fecal indicators like HF183 to normalize our data. So on the screen, you see the fecal indicator HF183 concentration across some of our sites in Dhaka. And when you look at the plot, for most of the sites, the fecal indicator concentration is pretty stable and consistent throughout the year. This is a 1 year data you're seeing. But for some of the sites in the red boxes, at a certain period of the year, there's a dip in the HF183 concentration, so it declines. So when we look back at our map of those areas, so these are the areas, you see all these sites are actually nearby a big river. So when there is a monsoon period going on during that time, so probably the sample got diluted and the HF183 concentration declined. That's why you see that dip. So we may have to normalize our data using this HF183 data we have. So in conclusion, in summary, as I kept saying, the engagement with the government and the public health stakeholders, the government agencies are really, really important to have an impactful research, public health research. And in terms of having a map, good map, mapping of your sewage system, and also getting the catchment population that are living within the catchment are essential for sewage implementation, sewage surveillance implementation. And some of the important factors that we found are to select the sites where the catchment population, total dissolved solids, the oxidation reduction potential, pH, and temperature. We found that the total dissolved solids were positively correlated with the detection of polio and enteric viruses in the wastewater. And lastly, the sewage surveillance was not meant to replace the clinical surveillance, but the idea was that sewage surveillance will provide valuable complementary data, especially in settings with limited or no reported clinical cases. This is our ES team. We call it ES team, Environmental Surveillance Team from Imperial and then University of Virginia. And our ground team in Dhaka, ICDW, they do the heavy lifting for us. Thanks to all of them. And I humbly thank to all of our funders, all of our collaborators, public health stakeholders, and our funders in Gates Foundation. Thank you.
Now I have questions. If I could get Brian back online and Dr. Andrews is on here. Oh. You know the drill. If you have a question, please come to the mic so the people who are online can hear you. And if you'll identify yourself and then give us your question.
Start with one online. Hold on. All right. There were a couple questions online that Brian answered, but I thought other folks would be interested. And Brian, if you want to take a minute to weigh in. There was one question about what smoothing function are you using for Bethel? And you, Brian, if you want to jump in, feel free.
I was on mute. Sorry about that. Yeah, that was just the average of the cycle threshold value from the different samples that we took throughout the week, and then the total number of clinical cases for each of the different pathogens we were taking. Those are the what we displayed on the graph. And then of course the cycle threshold is an inverse cycle threshold value because the higher the more cycles before detection, the less of the pathogen that you're going to see in the wastewater.
Okay, and we still don't have any, don't be shy. There's the microphone stand right there. Feel free to ask your question, but we had another one online, which was given that your wastewater and case data, this is for Brian again, generally match temporarily, one could argue that the wastewater data doesn't have a lot of predictive value here, and case data will provide a clear enough picture of actual infection rates. Are public health authorities using the wastewater data in Bethel? And you had an awesome answer to that, Brian, which I'll let you share.
Yeah. Right. So right now we're testing nearly everybody that comes into the hospital for respiratory symptoms. We had a lot of COVID funding for COVID tests. And so it was great to see that there was a strong correlation between the clinical data and the wastewater data. We receive an encounter rate for most of our patients. We don't do bill for services. So if a test isn't clinically necessary in the future and there's not extra funding for it, we might not perform that. And so as we test fewer and fewer people, it's nice to know that the wastewater data is reflective of what we would see clinically if we were testing everyone, as we expect those testing numbers to decline in the future. Additionally, we don't report out our clinical data on a regular basis. Sometimes they're really small numbers, and so we don't just share that publicly, but we can share the wastewater data publicly. So it allows us to real-time update the public, and we keep that website updated. We report it out every single week, so anybody that's interested can see what's circulating in the wastewater. And then finally, we rely on both the clinical and the wastewater for public health and healthcare decision-making here. So we don't just say one or the other. Sometimes we detect wastewater cases a little bit sooner than we do clinical, and sometimes we see some clinical cases before wastewater. And so we rely on both of those combined in order to make decisions about things like when to distribute vaccine, when to declare the end of an RSV season, et cetera. So it's just another tool in our tool belt.
Are y'all? Okay. Hello? Okay, cool. Hi, my name is Delise Amador. I'm a first year PhD student at the University of California, Merced, and I do have another question for Brian. I was just wondering about the different ways you attached the string to the more swabs.
Yeah, Alyssa might do a better job answering, but I'll do my best. So we have we attach the chain to a weight. The weight, it's like a 2.5 pound weight, just from like a small arm bell type thing that somebody had laying around their house. And then it's just lowered down into the lift station. The chain's just the right length to keep it away from the lift station pump so we don't damage any equipment. Then we go about a foot up, and then we have just a little clip that we clip on really heavyweight fishing line. I want to say it's like 50-pound test fishing line. And then that's sewn into the gauze to keep it connected to the gauze. We've tried different, they tied it on, they've tried a few different things, but sometimes they lose swabs. I see Alyssa joined us. Am I missing anything else, Alyssa?
Well, I just say we don't clip it on anything. We it's on a chain, so we stick the fishing line through it and then just loop it around itself, basically. But yeah, we did, after some trial and error, we did finally decide to sew it into the swab for extra security.
Do you have it in front of you? Can you hold that up again? Yeah, this is just.
I was preparing some while we were on the conference.
Thank you.
Hi, Alex Yu from California Department of Public Health. I had a general question, which is primarily around how environmental factors might play into what you see, or how you think about those things, like if there's heavy rainfalls or flooding events or things like that, that might impact some of the results you're seeing, if there's something you've thought about or that's helped in thinking about either avoiding or interpreting that kind of data or other types of corrections and things like that. Thanks.
Okay. Yeah, thank you for the question. I think I showed some of the part of the normalization of the data because of rainfall and other environmental factors that's affecting. So you need to normalize the data based on the normalization data you're using, like HF183 or rainfall, the dilution. I think it's important for my perspective.
Yeah, I don't have. Yeah, I didn't much to add. I do think because we're sampling surface waters, there's a very strong dilutional effect that goes along with the rain, and possibly normalizing might be a way to kind of handle that with some of the pitfalls that can introduce as well. But we have not yet been normalizing, but are kind of exploring that as an option.
Yeah, I have another question for Mohammed Islam. This one is, well, you presented a bunch of ways that you've gone about mapping the sewer system and the catchment areas, and it sort of evolved over time. And I was kind of curious if you could do it all again, right? Like you didn't necessarily, you'd want to spend 3 months, or maybe that is what you need to do. How would you go about doing that process? And what do you think is the kind of the most efficient way in a kind of unsewered or informal sewered setting, lower resource, to go about collecting kind of high quality data that you can use for mapping catchments?
Yeah, that's a good question. So we struggled a lot for mapping, especially for a setting like in Dhaka. It's very complicated. It's a very high dense population. So it's very hard to see where things are going in, who's connected. So we spend a lot of time on the ground to see who's actually connected. So we didn't try any other alternative methods to do it, but now we are thinking of an alternative approach to do it using the satellite images and drone images to track your main sewage lines. And if you can extract those features like manholes and other infrastructures that are associated with the sewage network, you can extract those features and feed it into the AI and an ML program that can create your sewage network, the primary sewage network. And then you can say how much of your sewage network is necessary to have that catchment and the population. Is it good enough to tell you the story that were told before, like the one we did? That's one approach we can go with. Yeah, thanks.
Hi, I'm Sophia from California Department of Public Health. I have a question for Jason. I'm wondering how you selected the sites that you sample, in the research that you're doing, and if there's a distinction in where you choose to sample based on kind of how you're differentiating research versus surveillance for your own work.
That's a great question. I think just to reiterate, we're really doing this as research projects and trying to demonstrate the utility so that it can be taken on as surveillance projects. And because of that, it's been done in a much more geographically focused place. I think we've had different approaches in different communities. So in Vellore, we were working with partners who had done very extensive sewage network mapping, very similar to what we just heard, so that we can do comparisons along time, real-time PCR, and that's really for the scientific purpose of validating those kind of data. By contrast, when we did sampling in Ivory Coast or Niger, the goal was just to determine whether or not there are typhi circulating there. We actually have no data whatsoever, and so is it there or is it not? And so when we do it that way, it was really convenience sampling. We tried to do geographically representative convenience sampling done in a very short period of time and what we would call kind of a rapid assessment, and just to give us a first kind of pass to say, okay, yes, it's there. Once we know it's there, right, then we can begin to develop kind of more formal systems for how we would monitor over time. In Kathmandu, we mostly took advantage of the fact that there's several large rivers flowing through Kathmandu, and a lot of the sewage flows into those rivers. And so it actually kind of provided this natural way to sample a very large portion of the population at once. And so we actually sampled like every 5 kilometers along the river, above Kathmandu, in Kathmandu, below Kathmandu. And what we saw was that sort of above Kathmandu, and as the river's flowing in, very little, if any, positivity. Center of Kathmandu, almost every sample is positive. And then as it flows out, we kind of begin to see it dilute out. So really it's, adapted to the settings. I think when you're working in non-sewered settings, you have a lot of decisions to make in terms of, what resources you have and how much granularity you need of the information.
And thank you to our panel.
All right, I'm ready this time. So I'm here to introduce our final plenary speaker. Dr. Prabhu Gounder is a medical epidemiologist with the Los Angeles County Department of Public Health, where he conducts surveillance and outbreak investigation for reportable infectious diseases. And he's here to share a more local perspective for LA County. So I'll hand it over to you.
Great, thank you. And we heard from a lot of experts today about advances in wastewater testing and sequencing. And what I wanted to spend some time doing was to talk about how we can use those tools to advance our use of wastewater beyond what we're doing now, which is detection and routine surveillance. So the perspective I'm going to bring to this talk is as an epidemiologist with LA County Public Health and as a physician who works in the inpatient setting at a local hospital. But I want to make it clear that I'm not an expert in bioinformatics or wastewater testing. But what I hope to do with this talk is to share my thoughts on what are some of the important clinical and public health questions that can be answered by using wastewater testing and sequencing. So I'm going to take a concentric circle approach. I'm going to start with an example, which is really just an extension of the routine surveillance that we're doing right now. And then I'm going to share a couple of examples where wastewater testing could provide us with additional context for interpreting the case-based surveillance data. And then I'll conclude with a couple of examples where wastewater testing can help answer questions that are really not easy to answer through traditional surveillance or clinical testing. So the first example that's on my mind is a hepatitis A outbreak in LA County. So you're actually sitting in the epicenter of this outbreak. Since January of last year, we've had over 170 cases. So this is a figure that shows an epi curve of the cases reported actually since September of 2023. That's when we started getting hepatitis A wastewater data from Wastewater Scan. And you can see that, you know, in a typical month, we get about 2 to 5 cases reported to us a month. But in April of 2024, we identified 3 cases of hepatitis A in people who are unhoused, who are within a very specific part of downtown LA. And those are the cases that are indicated in red. What was really helpful for us then was to look at the wastewater data because, again, we get wastewater testing data from 2 different plants. The one in gold is where is the area that covers where these cases occurred. And the one in purple is an adjacent to wastewater treatment area. And when we see this sharp increase that was out of proportion to the number of cases that were reported, it gave us an insight that there is probably a much larger outbreak going on, that there's a lot of undetected transmission. And at that time, we've been sequencing cases with risk factors. So people who are unhoused, specifically because we know that it's hard to interview. And the goal is to see if we could try to link cases together. And in this case, all 3 cases had a matching strain, suggesting that they're part of a common chain of transmission. So over the next 5 months, we continue to see additional cases in people experiencing homelessness. So that's the pink cases. We were also sequencing anyone else that we were incidentally able to get our hands on an isolate for. And we were starting to see an increasing number of cases in people who did not have risk factors. So that raised the question, how big is this outbreak really? Almost everybody we're sequencing then had this new novel strain. But what we didn't know was, is this because of a sampling bias? Because like I said, we're trying to select for people who had risk factors or some connection to the risk factor, or is it because it's so widespread in the county that that is all that's circulating? And to me, this is an example of an extension of surveillance. We're hoping to see that if we can do additional sequencing in wastewater to look for this very specific strain and figure out what proportion of all the wastewater concentrations are attributable to the strain. And then it would help us answer this question of how widespread this outbreak is. The next example I'm going to talk about is, again, looking at how wastewater data can provide us with some broader context. And this is looking at Legionnaire's disease. So just some quick facts for people who may not be familiar with Legionnaire's disease. It's a pneumonia that's caused by the Legionella bacterium. It's a serious condition. Mortality rates have been estimated at 10% and up to 25% in healthcare-associated cases. And Legionella is primarily an environmental pathogen. It's found in fresh water, but there are certain conditions, such as those that exist in complex building water systems, that allow it to amplify. And then there are certain devices within building systems like showers and decorative fountains and faucets that can disperse it. Cooling towers in particular of concern because they've been linked to large outbreaks. And if a susceptible person is exposed, they can get ill. And these include risk factors such as advanced age, underlying lung disease, and other immunosuppressing conditions. So we've seen over the last 20 years that there's been a steady increase in the number of Legionnaire's disease cases in the United States and in LA County as well. And it's hypothesized that this increase could be due to an increased exposure. So we have aging infrastructure and climate change, things that help amplify Legionella within the building water systems. But it could also be because the population itself is also aging and there's an increasing prevalence of chronic disease. So it's probably a combination of both. But because of the increasing number of Legionnaire's disease cases in LA County, there's a motion from our board of supervisors that we study and report back on how we can control Legionnaire's disease. And so we are proposing an ordinance to require buildings to have water management plans that can help mitigate the amount of environmental Legionella and help decrease exposure to the public. So this is where I think wastewater testing could be helpful. Again, Legionella is primarily environmental. So in this case, we're not looking for human cases in the wastewater, but by tracking the concentration of Legionella in the wastewater over time, and I should clarify in LA County that this is separate from the surface runoff. So this is primarily plumbed water that we're looking at. If we see a decline in concentrations over time, it could suggest that potentially our ordinance is working. So it's a way to help monitor our regulation, but also it can help us correlate with that trend that I showed you before, that increasing number of cases. If we also see a parallel increase in the amount of Legionella in our building water systems, then it suggests that part of the increase is in fact due to increased exposure. But if we see an increase in cases that is out of proportion to the increase in concentrations, then also suggests that the population itself is more susceptible. So it helps policymakers try to figure out where do we want to focus if we want to try to reduce the burden associated with Legionella. Another similar example would be hepatitis B. Again, a quick clinical primer. This is a chronic liver condition, really common overseas, about 300 million people with chronic active infection. And the region of the world with the highest number of cases is in Southeast Asia. It's a serious condition because there's an up to 40% lifetime risk of cirrhosis and liver failure, and up to 25% lifetime risk of liver cancer. And the risk for these outcomes varies by the HBV genotype, which is not something that's routinely tested in clinical practice. The complicated slide, but what I want to really highlight here is that genotype C is bad. It is the type that is most likely to really lead to chronic infection, more active disease that will then lead to cirrhosis, liver cancer, and it's also the one that's less susceptible to some treatments. And what we see when we look at a global distribution of genotypes is that the genotypes are specific to certain geographic areas. Genotype C in green is most prevalent in Southeast Asia. So now to tie this back to LA County, 1 in 12 Asian Americans are thought to have chronic hepatitis B. And in LA County, we have 1.5 million foreign-born Asians. So just to do the math, that works out to about 125,000 people with chronic hepatitis B. A separate study showed that LA County has the greatest absolute number of liver cancer cases in the US. And it's likely that hepatitis B is a leading reason for this. And what we wanted to know is whether wastewater testing can help us corroborate this. Kyle Bibby is one of the collaborators. He's not here, but he did a modeling study that showed that it is feasible to detect hepatitis B in wastewater. So the next step for us is to see, can we then go deeper and not just look at trends in hepatitis B, but what proportion of the hepatitis B is attributable to different genotypes? And if we could do that, what we would hypothesize is that genotype C would be the most prevalent in the wastewater because of where we know people in LA County immigrate from. And it would corroborate what we would suspect in terms of hepatitis B as a leading cause of liver cancer in LA County. Another example would be Streptococcus pneumoniae. So this is a pathogen that I worked on before I came to LA County. Again, a leading infectious disease cause of death in children and older adults, but it's what we call a bacterial respiratory pathogen. So it colonizes the throat and it's transmitted through asymptomatic droplets. Colonization is very common. Up to 70% of children and up to 5% of adults have it, but it's the clinical symptoms that we care about. And it can cause mucosal infections like sinusitis and middle ear infections, pneumonia, and invasive disease where it can translocate into the bloodstream and cause meningitis. There are, however, vaccines that are available that target the serotypes that are more likely to cause invasive disease. And optimal surveillance for strep pneumo would involve both looking at trends in colonization and invasive pneumococcal disease. But it's really challenging to look at trends in pneumococcal colonization. So this is a complicated slide from a group that I worked with when I was up in Alaska. But to know what colonization looked like in the community, we were swabbing about 4,000 noses a year. So we're going into the YK, as our recent colleague spoke from, all over Alaska to collect specimen. And what we saw, and we do this every year, and what we saw over time in this figure here, it shows the percentage of colonizing pneumococci that are one of the 7 serotypes that were included in the original pneumococcal conjugate vaccine versus not. And the vaccine was introduced in, I believe, 2001. And after the introduction, we see a reduction in that dark gray line, which represents a reduction in the vaccine serotypes. But we also see an increase in non-vaccine serotypes, which in this slide, looking on the left, is the serotypes that caused invasive disease before the vaccine. On the right are the serotypes that cause invasive disease after the vaccine. And we see that there's a reduction in the vaccine serotypes, paralleling what we saw in the colonization data. But there's also an increase in invasive disease caused by some of the other serotypes that we started to see increasing as a percentage of all colonizing pneumococci. So it's this type of information that is used to inform vaccine development. So not only is it important to know how the vaccine impacts colonization, and we know that there's going to be replacement types, but we need to pair it with invasive data to know which of those are of concern, and then which of those need to be targeted for the next vaccine. So there are specifically 6 other serotypes that were accounting for invasive disease, which led to the introduction of a 13-valent pneumococcal vaccine in 2010. And again, after the introduction of the 13-valent pneumococcal vaccine, what we see on the left is overall colonization by age, and on the right is what we see in terms of colonization by the vaccine serotypes. So colonization by vaccine serotypes went down, but overall colonization stayed the same, suggesting that there's non-vaccine serotypes that were increasing. And again, we would need to map it with invasive disease data to figure out which one of those are concerned. So we have invasive disease data, but it's really hard to get colonization data. And again, this is an example where I think wastewater testing could be helpful. Ideally, we would not only be able to look at trends in strep pneumo over time, but we'd also be able to determine the serotypes. And again, instead of a colonization survey that is a convenient sample of a certain number of children in a certain area, this would potentially be a community-wide profile of what's circulating. And we would be then able to correlate that with our invasive data to better understand the impact of vaccines and inform vaccine policy and vaccine development. So the last example is looking at something that I'm hoping wastewater data would be able to help us with, which is creating a community antibiogram. And so first off, for people who are not familiar with antibiograms, this is an example from the institution that I work at. Usually most hospitals, they will track and monitor the pathogens that they're culturing from the different sources. And they will try to put into a figure the percentage of those isolates that are resistant to the different classes of antibiotics. So on the left are the clinically important pathogens that we follow. And then again, the figure shows the percentage that are susceptible to these different antibiotics. And the reason the antibiogram is important is because a lot of times when people present to the hospital with an infection, you don't know what they have. So we take a syndromic approach. If someone comes with a pneumonia, we know that there are certain things that cause pneumonia. If someone comes with sepsis, we know that there are certain pathogens that we want to cover. And so then we look at the antibiogram to figure out, of the pathogens that are most likely to cause this infection, which is the antibiotic that would be the best to use. And so we would come up with empiric antibiotic treatment recommendations, and this is usually done by the hospital pharmacist or hospital epidemiology team. And so there's it's published, and this is again from our hospital, where for every type of infection, they come up with specific recommendations for how you should treat it based on the susceptibilities that were identified within that institution. But the problem is the hospital-based antibiogram might not be representative of infections that you see in the outpatient setting. Someone who has a middle ear infection is not necessarily going to be coming to the hospital. Someone with the community-acquired urinary tract infection is not going to always come to the hospital. So if you're a community doctor and you want to be able to make the best decisions you can about what antibiotics to use, you may rely on your hospital antibiogram, but you may live in a community where that doesn't exist. And so we wanted to see, is it possible to create a community antibiogram? And I'm going to talk about a specific use case for where a community antibiogram would be helpful in a public health context, and then talk about some preliminary work that we've done to try to answer this question. But Streptococcus pyogenes, or group A strep, it's something that we track because it's an important cause of invasive disease. and especially in nursing homes, a really high mortality. I want to say every year we respond to about 10 to 20 outbreaks of invasive group-based strep in nursing homes, and they always have very high mortality, anywhere from 10 to 50% or higher. One of the things that we try to do in nursing homes is, because it's a respiratory pathogen transmitted by droplets, we would try to swab everybody and see who's colonized. And if they're colonized, we'd want to prescribe antibiotics. Sometimes that doesn't work because the testing for the colonization is not always 100% sensitive. So we may just recommend treating everybody within a certain unit. Azithromycin is the antibiotic that would be easiest to use because it's once daily, 5 days. And so it would be the easiest to take. But there is increasing resistance to azithromycin, so you would not want to use it unless you know that the group-based strep in your community is susceptible to this. And in the absence of that sensitivity data, your options are not as good. It's giving an intramuscular shot of penicillin with rifampin, or taking another medication that you have to take for 4 times a day for 10 days. And so this is work that we did in combination with colleagues here at Zymo and Phase Genomics. They tested some of our wastewater data last year using a method called proximity ligation, where they're able to associate mobile genetic elements with specific pathogens. And to me, this is the key. It's helpful to know what the antibiotic resistance genes are, but from a clinical and public health perspective, what I really want to know is what is the susceptibility of these different pathogens. And so this is an analysis they did, so metagenomic sequencing with proximity ligation, and focusing on our specific pathogen of interest. They were able to get down to the family level. And we look at Streptococci, we see that there's a very high abundance of resistance genes that correlate with macrolides or azithromycin. So again, this is preliminary proof of concept, but does show that it is possible that to eventually get to a point where we may be able to get a community antibiogram. And again, looking at the nursing home outbreak as an example, it's a very clear public health use case for how wastewater data can help us answer questions that might not be easy to answer otherwise. So again, the main thing I wanted to do today was to share some examples of use cases, but it's not intended to be specific to those pathogens as much as to stimulate us to think about, what are the other ways that we could use wastewater data in addition to detection and surveillance, so we can really uncover the full potential of wastewater surveillance to impact public health and clinical decision-making. Thank you.
Well, thank you, Prabhu, for that. And we are not going to do Q&A now because I know we're all going to, our minds are already on happy hour networking. But if you have questions, please, please connect with Prabhu over, or will you be at the meetup? Awesome. Connect with him over drinks. So can we just give another round of applause to everybody? That was an amazing. We really appreciate all our speakers. Yes, I have not forgotten Heidi. Heidi's remembering, reminding me a couple things. Okay, stick with us for 5 more minutes. I'm gonna just talk about what's going on tomorrow, and then Alex is gonna close out with some words. So just 5 more minutes, that's all we need from you. Okay, day 2 looks different. So we were all in this room today together. Day 2, we are going to be in different rooms, and we're gonna be split up into 3 tracks. So please make sure you choose the track that you want to go into tomorrow. You can get to this link from your digital agenda. You can also get to it from the QR code. I will leave it up for a few minutes, but you got to choose one of 3 tracks. There are 3 tracks in the morning, 3 different tracks in the afternoon. You can mix and match. You don't have to stay in the same room all day. Those rooms are not going to be here. Those are going to be the green rooms, the greeny chartreusey rooms on this map here. Yes, exactly. So Stephanie, nice job pointing. We're not going to be here. You're going to be closer to the main entrance and closer to the entrance from the parking that away. And there will be registration tomorrow morning again in between where the place where I've circled there. Okay, did everybody get the QR code to choose your track? Going once, going twice. Okay. It's also in the digital agenda. All right. Here is where I'm just going to take another minute and then turn it over to Alex. Okay, so Water Environment Federation. We've been working with funding from the CDC under a 5-year cooperative agreement. This is our final year of that cooperative agreement. And we have made the decision, as many of you know, and I've communicated out, to not apply for any no-cost extension beyond FY25. So that means WEF's CDC-funded activities will wrap up on September 30th of 2025. And we do the summit, but we also do a few other things. So we've been doing a lot in the last 5 years. We are not going to abandon this whole enterprise of wastewater surveillance. We are looking forward to finding creative ways to continue some of the higher value activities that we've done over the past 4 years, 5 years, whatever. And that will include some version of the Wastewater Disease Surveillance Summit. We're not sure what that looks like, but we're going to figure it out. We will also likely continue some version of the News Utilities Community of Practice. Again, not sure what that looks like, but we'll figure it out. We're committed to things like helping continue to develop the wastewater and environmental surveillance curriculum. I mean, there are things we're going to continue without CDC funding. We want to continue partnering with all the amazing folks doing this work. So we're not going away. But that said, we want your ideas. We want your ideas about how WEF can be of most value to this community going forward. So you have a few options for sharing your ideas. One, another QR code. So that takes you to an anonymous survey link, and we'll share this in the follow-up email to all of you after this event. You can just throw an anonymous suggestion in there. You can find me or Carly or Heidi at the networking event or sometime tomorrow and say, hey, I really think WEF needs to be continuing to do this. Or you could email me, and I know you all have my email address, so there's no excuse there. All right. 2 more reminders. One, we've talked about the networking event. It's at the Carl Strauss Brewing Company on Wilshire Boulevard. We're going to meet from 4:30 to 6:30. This QR code, yet another one, takes you to a Google Maps link. It's not walkable, but it's ride shareable, or it's you can go to Union Station, which is right across the street, and jump on the Metro B line, and it's a very short ride. So you have options. So please join us at Carl Strauss. We'll wrap up there around 6:30. But before you go to Carl Strauss, we want you all to go out into the courtyard, and we're going to take a big group photo if you're willing to do so. Yes, ma'am. You have your Metro leader over here, Sarah. Thank you, Sarah. Okay, excellent. But yes, before you go to the Metro, please just hop across the hallway here into the courtyard, and Heidi is going to take a group photo, because who doesn't love a massive group photo? All right, that's it for me. I'm going to turn it over to Alex.
Just 1 minute. I was just going to say a quick thank you to everybody for coming here, for being here and supporting this community, to Anna, to Carly, to Jennifer, to WEF for helping host this, and the California Endowment. This place is amazing, and it's really heartening to see this community grow over the last few years. I know a lot of people here have been in the space for a long time, and I think I first was introduced to environmental surveillance about maybe a decade or so ago, working in Jason's lab and thinking about how we can use wastewater surveillance, or water surveillance, I guess, to think about gaps and how do we use that for public health and for targeted health things. And also then thinking about how we can use it for Legionella or other things where there are gaps in surveillance in what we do. And those are the same kind of questions we're asking today. And so in some ways, I feel like we're asking the same questions and we're still trying to push the same issues. But at the same time, if we think back just how far we've moved in the last couple of years, really because of all the work that you guys have been doing, it's really incredible how far we've come, right? I mean, we can throw a wastewater COVID graph on the screen and it looks exactly like an epi curve, right? Like that's like unthinkable if you had told me that was going to happen 6 years ago, right? Or that we're talking about pandemic response. And so in the same ways that we're still all doing the amazing work that we're doing that takes so much effort, I think as a community, we're able to grow and build this field. And despite all the uncertainties in the world around us, I think this field will continue and will continue to progress because of all the, this field is fun and people are passionate about it. And I think it's going to take that to move us forward. And so I'm excited about this, and I'm really heartened to see how many people are able to join us here virtually as well as in person, despite all the challenges, and look forward to more of these opportunities and collaborations and efforts and projects in the future. But thank you, everybody, for joining and for being here today.